Good morning, everyone. We are
Good
all
morning, sir.
welcome to
Good
the
morning.
session. Sorry for starting a little bit late. This week we will be discussing trunk control and trunk balance, and the presentation is going to be in two phases. The first section is going to be from now to around 12 or 1 o'clock, where we shall be discussing postural control and then sitting balance in stroke, Parkinson's disease, and other neurologic dysfunction by extension. And after break, the second session will also begin by Dr. Muhammad Ali Abba. So I hope we will have an interesting discussion as usual, and then benefit from the little we are going to be sharing with each other. So the presentation is going to be on seated postural control and balance, and then it's going to be under the following headline. The aims will introduce the concept of sitting balance, and then we shall take 3 major tests or scales used in assessing or evaluating seated postural trunk control or balance. So the main purpose of these presentations are basically 2 or 3. One, to understand how trunk control is, or how trunk control is regulated, and then how to characterize sitting balance, and also learn or improve on our ability to assess stroke control and seated postural control, and at the same time to get encouraged to apply these techniques or tests or skills in our daily practice in the clinic, bearing in mind the appropriate population to be used, the stage of recovery to be used for, and then the appropriate timing, and then the purpose of which we are applying the scale or tests for. So sitting balance is an important aspect in rehabilitation of stroke survivors, or even in rehabilitation of neurologic dysfunction in general. However, specific to stroke survivors, sitting balance, the importance and the benefit of having proper sitting balance cannot be overemphasized, because an individual, a stroke survivor's ability, or a predictor of a stroke survivor ability to have an independent and autonomous functioning later in life, is the ability to maintain proper and appropriate sitting balance. So that is why the first item it says is a vital predictor of functional recovery. This is to say the ability of a clinician to properly manage and treat stroke survivor to have a good or a better trunk balance will translate to a better functional recovery later in the continuum of recovery or care of that stroke survivor. Therefore, the use or the focus in targeting or aiming at better sitting balance in stroke survivors is an integral aspect in the rehabilitation of stroke survivor. That is why it's usually recommended or suggested that stroke rehabilitation experts should pay much more attention in trying to provide treatment and care or rehabilitation to stroke survivors on bed or pre-ambulatory stroke care. Those care provided to stroke survivors go a long way in predicting the level of functional recovery that individual or that stroke survivors will have in life. As such, sometimes it might not be a wise idea to rush our patients to manage, to ensure that we see that quick, we see that our stroke survivors started walking or start standing without adequately giving attention to areas pre-ambulatory care that have to do with areas such as sitting balance and the related areas. Secondly, this sitting balance also is translated, apart from having an important predictive value for functional recovery, it also has the ability to affect the activities of daily living. So the ability of stroke survivor to perform or to execute daily activities is also affected by the sitting balance ability. Therefore, if such is affected, definitely the everyday tasks or activities that such individual will be engaged in will be affected, and the autonomous living of that individual will also be affected. As such, the value of sitting balance and the related elements associated with this are so integral in the rehabilitation of stroke survivors. Hence, we shall be discussing what are the skills, tests, or measures to be used in tracking the progress or recovery of stroke survivors, seated postural control, sitting balance, and the likes in the continuum of care of stroke survivors. This is a brief introduction relating to what we should be looking at subsequently. So the first area we should be looking at is the area of stroke control tests, usually abbreviated as TCT, usually in a standard abbreviation. Even in literatures, TCT is used as an abbreviation of stroke control test. So it's not a mistake if you use it during your documentation in your folders while you see your patient. It's one of the standard abbreviations used to denote or signify stroke control test. This is a simple test that can be performed in few minutes, and it is designed or originated for assessing or evaluating trunk movement in 4 major areas. We shall be seeing the areas as we move. So this basically assess the ability or the trunk movement in stroke survivors in 4 areas. And the main target population that this scale can be used is stroke survivors, brain injured individuals, individuals with spinal cord injury, older adults, among others. So it does not really require special equipment or requirement to be able to carry out the test, while some skills we saw previously in the last week workshop, we shall see some skills that require some little additional special equipment. This skill does not really require any special tool to be used during the assessment or evaluation process. The only important thing that I will keep emphasizing in each case is the ability of the therapist or the therapist to be well acquainted with the concept of balance, posture, and pose. Because without having knowledge or being acquainted with those, there should be some difficulties along the way in understanding some concepts. So the scale is usually a 4-item scale. So that's why I say it's a simple scale. And each item is scored, or each task in that item is scored on a 4-point scale. Sorry, it's supposed to be 3-point. This is a mistake because the scale, you can easily score it either 0, 12, or 25. And the maximum score you could get is 0 or 100 because, yes, it's obvious since the scales are 4. If somebody gets 25 in each of the 4 scales, that is the highest or the maximal score. When you add the 25 or multiply 25 by 4, you have 100. That's the upper limit. And the lower limit is obvious. Once anything multiplied by 0 will give 0. So the scale individual could have a score of 0, or individual could have a score of 25. This scale is a very important scale because it's, apart from using it in stroke survivors, it's been used in several populations, and it has been validated for use in these populations because it's apart from being simple, but it's very vital in trying to evaluate, show how trunk movement is in several areas in stroke survivors. So we shall be seeing it's how it affects those areas and how it shows movement in those areas. One important aspect with the scale is that it shows a very good sensitivity to change in assessing recovery of stroke patients. So because of that sensitivity of this scale, it makes it very vital in use in stroke survivors. It also has the ability to capture basic motor skills. So that is to say, it can capture basic motor activities or skills during the recovery aspects in stroke survivors. And therefore, this makes it to mimic or to be comparable to other skills or outcome assessment tools that are used in capturing those aspects in stroke survival. So it's a simple scale, but a very mighty one in terms of importance in stroke recovery. Some of the areas it examines involves rolling. That's the ability of patient to roll from supine position to the areas that is either the affected side of the body or to the unaffected side of the body. It also has the ability to check or to assess the ability of individuals to sit up from lying down position, and also the ability of an individual to sit in a balanced position on the edge of the bed with the foot off the ground for about 30 seconds. So this gives it a very important value. And this scale 0, 12, and 25 are usually given with lower values showing lower independence ability. That is to say, this scale is also a positive scale. Higher values indicate good performance or better trunk movement or trunk performance, and lower values indicate worst or bad trunk performance. 0 usually is given when an individual cannot be able to perform movement without assistance. So once there will be an aid, support, or any kind of help to execute any of the 4 tasks, 0 score will be awarded to such tasks. However, in a situation whereby an individual or a stroke survivor can be used or can be able to perform the movement but in an abnormal way, that is, the individual is able to perform the movement not with help or assistance, but can only perform it in an abnormal pattern or abnormal way, a score of 12 is allocated to such a task. And then when an individual can successfully and completely perform the task normally without any difficulty, then a score of 25 is allocated to such task when it's being scored. So the items in the scales are as follows. There are 4 as discussed. We have number 1 as ability of a stroke survivor to roll to the affected side, to the weak side, to the paretic side. Any language is correct. So once a therapist asks the stroke survivor to roll to the weak side or to the paretic side, if the stroke survivor cannot be able to execute such tasks unless with the assistance of either the physiotherapist or the caregiver, then a 0 score will be allocated to such a task. Then the second task is the ability of the stroke survivor to roll or toward the non-paretic side. Such is also going to be scored based on either the score is either 0, 12, or 25. The third task is balancing in sitting position on the edge of the bed with the feet off the ground. That is to say, the feet are not to be supported. No support, no chair, because when we move forward, we shall be seeing one of the tests that we should have feet supported and at the time feet not supported. So in this situation, we are talking about feet not going to be supported. It's off the ground and it has to be for a minimum of 30 seconds. The score is also going to be allocated here based on the ability of an individual or a stroke survivor to perform the task. The task, which is number 4, is sitting up, or the ability of the stroke survivor to sit up from lying. So if the stroke survivor can sit up completely from lying without being assisted and can execute the task normally and successfully, not in an abnormal way, then a score of 25 can be allocated for execution of such task. So at the end of the day, the score obtained for each of these individual items, the 4 items, will be added, and the overall score for an individual will be obtained. The psychometric properties of this scale has been tested, and it was found to be valid for stroke for evaluation of stroke survivor stroke control. It was also found to be reliable in this population, and is responsive. You can hear me at the beginning saying it's very sensitive to change in the recovery of trunk control in stroke survivor. So literatures have proven that this scale is valid, reliable, and responsive, also sensitive to change in stroke recovery. So that is that about that scale, which is a simple one. We will discuss all the scales. Our subsequent workshops are going to be basically on the follow-up practicals and hands-on on all these things we have been discussing, so that we can put them into practical use for better comprehension. So the next scale we shall be looking at is called the Ottawa Sitting Scale, usually abbreviated as OSS. So this Ottawa written scale, sorry, before I move to Ottawa, so in essence, we could see that when we are looking at the stroke control test, it's a scale that we could use during our inpatient rehabilitation. That is, even before stroke survivor is discharged from the medical ward, or even when the stroke survivor in the acute stroke unit, even before being transferred to the main ward, as far as the stroke survivor is medically stable, we can be able to start using this scale once the individual can be able to obey command and is conscious and is medically stable. That is to show us, because our ability to get to record or to get the detailed information of what is the stage of the recovery of our patient will really help us in tracking the progress of what we are doing to the patient. So our ability to really measure or assess or quantify this component or these parameters at early stage as soon as possible will really help us to track the progress as we treat the patient, number one, and number two, it will even also give us the ability to predict what will be the likely recovery or functional recovery of this patient, even up initio before we even go further in the management of that patient. So this is to say, this is a scale of choice, even especially at inpatient rehabilitation during in the ward when the patient is still on admission before even coming for a start, before the patient starts coming for outpatient visit to physiotherapy. So the next scale is Ottawa Sitting Scale, or OSS. Is usually planned or organized or produced to characterize sitting balance. And it's a scale that is usually targeted at stroke survivors and even individuals with Parkinson's disease and other. But one of the key uniqueness of this scale is that, or specificity of this scale is that it's also applicable majorly or particularly at acute phase of rehabilitation. So it's also an important scale that can be used at inpatient rehabilitation. Unlike other measures of balance, this scale solely, exclusively targets sitting balance. So if you look at some scales of balance or posture assessment, you see that they will combine some maybe sitting and standing balance, or they will have some element of combination. This scale, one of its particularity or peculiarity is that it's solely and exclusively focused on sitting balance. So this is to say, when a clinician is solely interested in quantifying or evaluating only the sitting balance of his or her patient, so one of the best scale for choice should be Ottawa sitting scale, which can be used in sitting. So it usually does not also require some special requirements for testing. The only requirement is your understanding of balance, posture, and pulse related concepts. Then the scoring of the scale is a 10-item scale. You could say 10, but or you could say it's 5 scale. They are all correct. Why I said that is that the scale is the 5 items in the scale are still the same. The item 1 to 5 are still the same item 6 to 10. What all differs or what makes them to be different or distinct is that while item 1 to 5 tasks are performed with supported feet, that's the feet is supported, items 6 to 10 are performed without support to the feet. That is with feet unsupported. However, each of the items in the scale is scored on a 5-point scale from 0 to 4, 0, 1, 2, 3, 4. And the range of scores that you could obtain is that since the item, for example, are 10, sorry, if individual has to get 4, which is the maximum score per each task, per each of the 10 tasks, then you could have 40 as an upper limit or maximal obtainable score that an individual could get. And then you could have 0, that is the minimum. So in essence, this is saying this scale is also a positive scale, not a negative one. That is to say, as the values or the scores increases, the better the sitting balance of a stroke survivor. So this scale has the ability to assess or evaluate static sitting balance posture or position. It has the ability to assess or evaluate reaching ability of an individual. It has the ability to also assess the rotation or turning of the trunk. So the trunk turning ability of stroke survivors can be quantified by this scale, and also movement on the bed can also be quantified by this scale. And as I said, it's a positive scale with lower score. That is, if an individual can perform with a worst performance, you give the score of 0. An individual that can perform with a best performance will give a maximal score of 4. So the higher scores signifies or denote a better sitting balance, while lower scores imply poor or impaired sitting balance. For example, let's just take example of maintaining static sitting posture. For example, if an individual can maintain balance within the midline posture for 60 seconds, if a stroke survivor can maintain that, then you can give him a score of 4. That is, can maintain static sitting balance posture within the midline without tilting, without falling, sitting still, and maintain that for 60 seconds, then that individual can be awarded a 4. However, if such individual can only maintain balance but lean toward one side of the body, that is to say, the individual cannot be able to stay on the midline in a normal posture. The person or the stroke survivor has to lean toward either paretic or non-paretic side for at least 30 to 60 seconds. Then the score of 3 should be awarded to such individual. In a situation whereby the individual can maintain the midline posture, that is, the stroke survivors is able to maintain the midline posture, is not leaning toward either side, However, the leaning posture, the midline posture can only maintain for only 30 seconds or less, then a score of 2 shall be awarded to that task. Then, if the stroke survivor falls from sitting position, but has delayed postural reaction, that is not that just the stroke survivor just fall, no, but the stroke survivors like shows tendency to fall before falling. That is to say, it he or she maintains certain level of sitting posture, even if for some few seconds, then move toward maybe started leaning, and then fall. Then that a score of 1 should be awarded. However, in a situation whereby the individual falls straight without establishing or demonstrating any postural reaction, once on this in sitting position, the individual falls down, then a score of 0 shall be awarded to that individual. So this is how 0 to 4 are broken down in trying to maintain or to score the individual during measuring or assessment of static sitting position in Ottawa sitting scale. So that is how it's moved. It moves. It moves like that. So these are the items. As I said, you could see that the first section is feet supported, items 1 to 5. That is maintaining a static sitting posture with feet supported. Moving short distance with feet supported. Moving long distance with feet supported. Then rotating the trunk or turning of the trunk. But please remember that we are all talking about sitting here. So even if we say moving, we are talking about in sitting, so that we should not be mistaken it with what we did last week with balance scale that has to do with standing or walking. Then we have a sitting or walking on hips. Why I write sitting or walking, this scale was originally developed with a 6-item scale. This Tonton developed this scale, and and colleagues, they developed this scale. The initial scales were supposed to be 6. That is to say, number 5 is supposed to be sitting on hips, and then number 6 walking on hips. However, as researches keeps going on, the scale is being modified to only contain 1 item that has to do with sitting on the hips. I really did not really conceptualize why the need to remove one of the items, but I speculate maybe the concept of redundancy. Likely, I'm not sure, maybe the 2 items may be given the same concept. So maybe the subsequent scientists that modified the scale felt or found maybe in their analysis that one of the items is redundant, as such maybe it was expunged and made the scale to be 5 items instead of 6 items, because that is one of the ways to do it. To run the analysis, there are some analysis that will show you the redundancy, like Chromebook Alpha will show you that certain maybe scale are redundant, and then if you expunge certain scale and reanalyze your data and see a better result, you could have justification in removing some item from a particular scale when you are trying to test its psychometric properties. So that may be the reason why the scales from the original developers were 6 turns to 5. Because if you check, the original developer says there are 12 items and the maximum score that an individual could get is 48 instead of 40, because there are 6. But since we are talking about the recent or the most updated, that is why we work with the 5 items instead of 6. So the second 5 are still the same thing as the first 5. What only differ or make them different or distinct is the ability to not have support. So here, while the task here in the first section or segment is being performed with feet supported, in the second segment, the task is going to be performed without support to the feet. So that's what differentiates. The psychometric properties of this scale has been tested or has been checked, and it was found to be valid scale for stroke and Parkinson's disease, especially in the acute stage. We can also see, as in the case of trunk control, so this is also a scale of choice when we are doing our inpatient rehabilitation or even during our outpatient when we are managing our patients that are at the acute phase of recovery. Because if we use the scale at appropriate stage of recovery, we are likely to see the better part of the scale, and it gives us the accurate information we require, and it helps us in making appropriate treatment planning. That is why it's usually important to emphasize this aspect of the population that the scale is being validated for use, and also even apart from the population, at which stage of recovery the scale is best to be used, so that it can be used more suitably and more appropriately during rehabilitation of patients. It was also found to be reliable in stroke patients and Parkinson's disease. Many components of reliability has been tested in this scale, like intra-rater reliability, have all been tested, and apparently the scale has been found to be reliable for use in this population, and it has been compared with other similar standard balance measures, and has been found to show close comparison, or comparatively close with other standard balance scales that are being used in rehabilitation. The uniqueness of this scale, I don't know, I'm seeing something cheaty, something on the slide. I don't know. That is okay. So it focuses solely on sitting balance, and it can assess individuals that are non-ambulant. So as I said initially, it has the ability to assess individuals who are not ambulant, so who are not working. So their sitting balance can easily be assessed with this scale. And then this scale, one good thing with it is that the literature has clearly stated that this scale is useful and valid for use both in research and clinical practice. There was that emphasis that the scale is valid for use in research and also in clinical practice. So that is a plus for the scale, and it shows that this scale is good to use, especially at the acute phase of recovery, because it gives us ability to track the recovery of our patients at initial when we are starting the rehabilitation of our patients for better outcomes. The next scale is called function in sitting tests. So, function in sitting from the word. This function in sitting test is designed to be used for assessing balance at bedside. You could see almost all the skills I'm trying to discuss today are more or less being used in inpatient rehabilitation. That is they are being used in in with not at outpatient, or they could be used at outpatient, but the main target is for them to be used at before maybe ambulatory rehabilitation. Usually I've been used pre-ambulatory because they are all discussing trunk and sitting balance. So the target population for this scale include stroke survivors, neurological dysfunctions, even in general, what it could be vestibular dysfunctions and the likes. So the requirement is that this, apart from the use of or the knowledge of the concept of a balance and posture, there should be a standard hospital bed with no air mattress. That's right, with no inflatable or mattress that will support balance. So this required to be a presence for this test to be carried out. The test has a 14 items ordinal scale, and each scale is scored on a 5-point scale of 0 to 4. So the total obtainable score is by totaling or adding the individual item scores, and the overall obtainable scores could be 0 or 56, depending on the performance of the patient while carrying out each of the tasks. So now it has the ability to measure or to quantify elements that are related to sitting balance, that has to do with maybe sensory or motor balance related elements, reactive balance, proactive balance. You shall see how it has the ability to measure all this when we are discussing the detail of how the assessment is, how the test is carried out. So it has the ability to measure this proactive, reactive, steady state, motor, sensory. Can you see why I said that understanding the concept of balance and postural terms is important? You could see we discussed these terms in detail last week. All these proactive, reactive, steady state, and the likes. Because most of these skills use a lot of these terms. So that is why it's important to have those terms at our fingertips while trying to discuss this balance rehabilitation or sitting assessment or evaluation in function. So all these components. So this is to say, if a clinician is interested in having to assess or to evaluate proactive, reactive, motor sensory, steady state balance all together or some combination of them. So one of the best, and this balance, I mean all these balance elements in sitting. So this Ottawa the function in sitting scale fist is one of the best tests or modality or technique of choice that a clinician selects to give appropriate rating. Why I kept emphasizing on this is because every patient is specific. And when patient came to an individual or to a clinician, the clinician has the ability to assess and test the patient to see what are the things that are wrong or that the patient is complaining of. And so when the clinician puts those assessment or those information data together, it will be able to guide him or her on the best or the appropriate scale to select when trying to assess for any particular parameter in the stroke survival. So that is why I kept emphasizing or trying to specify for each scale what is supposed to be used at which stage, at which level of recovery, for which population and at which condition that it could be used, which and that will help us trying to be more specific as possible while trying to select this outcome as because there are many. So we are trying we are likely going to face a difficulty of selecting, or we might be confused, or on what scale to use or what test to use. But if we have the ability to understand that this is what differentiates this from this scale from this, that will help, really help and guide us to know, okay, this is the way, or this is what I'm supposed to choose at this situation because of particular reason. That will be the way to go. So the details about the scoring for these scales are detailed here. That is to say, this is what is 0 mean, what 1 mean, what 2 means, what 3 means, and what 4 means. So as usual, like the other scales, because this scale is also a positive scale in the sense that a lower score indicates worst performance, while a higher score indicates superior or a better performance. If you look at it, we said 0 is completely, somebody needs complete assistance. That is to say the stroke survival is completely dependent. So he or she has to be assisted physically to completely and successfully execute a particular task. Without being assisted physically, the stroke survivor cannot be able to successfully execute a particular task. If such is the situation for a particular task, then a 0 score should be awarded to that task. However, when the stroke survivors to execute a task, then a score of 1 shall be awarded to that task because the stroke survivors cannot be able to successfully complete that task without physical aid or assistance. However, the physical aid or assistance is making him to execute the task, but he is not completely dependent. So 1 should be awarded that item or task. When upper limb or upper extremity is must be used to support or to aid the task completion, then a score of 2 shall be given or awarded to the execution of that particular task. In a situation whereby the stroke survival require verbal cues, that is to say maybe verbal cues or tactile cues, or individual needs a lot more extra time to complete a particular task, then a score of 3 should be awarded to that task. So this is close to independence, but still the stroke survivor needs to be given some tasks, some verbal or tactile cues, or it takes extra, take extra time to execute a particular task. Then 3 shall be a score of 3 shall be awarded to that task. I think the scale is there on the WhatsApp group. I don't know if Hafiz can help us share it also on the yes on the send the scale on the platform. So So the last item is independent. When a stroke survivor is independent, that is, can be able to perform tasks completely and successfully and autonomously without being assisted or without having any hint of any kind and without wasting any time, then a score of 4 can be awarded to that stroke survivor for executing such tasks successfully. So these are the guiding principles or the guiding factors in trying to assess or to find out what level of score can be allocated to a particular task being executed in function in sitting test when it's been carried out. Now, there are instructions associated with this skill. That is why I dedicate a slide for that, because it's not like all other skills also have instructions, but this skill, particularly because of some things that are associated with it, that is why I try to emphasize the instruction associated with it. Number one is each item is supposed to be tried once. So that this is to tell us that when we are trying to perform this test, there is no, you could see that in some tests or some skills, we have a situation whereby you could even say among the instructions that you have some trial. You say, okay, you do 1 or 2 trial for the patient to get accustomed to the task before you even start the main task and give a scope. However, in this scale, there shall be no such opportunity. That is to say, the task is being practiced the way it is, and each task is supposed to be tried once. Once an individual tries it, the score should be allocated. There is no trial in this type of scale. So the only thing that is required here is that the therapist is supposed to discuss with the patient on what does this test entail, and what activity is the therapist going to perform on the patient, so that the patient will clearly know this and this will be done to me, and this is what I'm expected to do. But once the act started, there is no going back. That is to say, there is no trial, second trial. There is no second chance. There is no second option. Once a task has been tried, that is all you move to the next task and allocate the appropriate scope for that task. Very important. Then the therapist should be able to provide verbal instruction and demonstration as required. So this is still follow up to what I'm saying, because this has to do with sitting. This has to do with individual being on bed, sitting, and the bed is, that is to say, there are some level of instability associated with it. So that is why it's important to detail to the patient what the test or the scale shall entail, and then also tell the patient what to expect while during the testing, and also give an instruction or demonstration even before starting, and what the patient shall do in case of any situation. We shall be seeing when we come to discuss the individual items in the scale of why we are saying these instructions and demonstrations are vital in trying to make sure that the test went smoothly. Number 3 is that a patient shall or should sit on the edge of a hospital bed with their hips and knees at 90-degree angle, their feet flat for support, and half of their upper leg supported. That is to say, just like an individual is sitting out of bed, like he's trying to sit up and like he's trying to stand, so that is say he's sitting, should have a picture But, well, from the instruction, I forgot that one. Supposed to have a picture. This one is just saying that the individual is on the edge of the bed, not completely sitting on the bed, but no, the edge of the bed is like dividing the individual hamstrings into two. So it's at the edge of the bed, and the hip and the knee makes 90 degrees. The feet are flat for supporting that individual. So the feet are on the ground, and then half of the leg is supported. That is, the edge of the bed is supporting the upper half of the leg. That is what it says. While the lower half is outside the bed. So then there should be normal lateral abduction, adduction, and then rotation. So we shall be able to see when we come to each of the individual scale. We have the scale. Please have this help us share the scale in the chat box. It's also in the WhatsApp group.
Yes, I shared it.
Okay, please. Thank you. So now, unless required for support, hands are put on the lap. So the instruction in this scale is that hands are always placed on the lap, unless they are required to support so that the individual will not fall from sitting, then they could be used. But otherwise, hands are supposed to be placed on the lap. So are we together?
Hello, sir. Please, I have a question. Can I have my question, sir?
Is it related to this?
Yes.
Okay.
I just want to clarify, sir. Thank you for the wonderful presentation so far. I'm the one that posted to send the PDF form. So my first
Okay.
question is, the Ottawa City Scale and the FIST, are they the same thing?
Oh, they are not. That's the question.
Thank you. So that one now leads to my question. Um, you may mention during the Ottawa sitting scale that majorly it can be used for among stroke survivors and Parkinson patients. But my question now is, you said the uniqueness about this particular scale is it can be used in a non-ambulant patients. So 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 I'm not asking, does that mean that you can use this particular scale in a elderly fry patients or patients that have been falling?
Okay. Uh,
The,
That's the question,
the
right?
Yes, then my second question, sir.
Yes,
So, okay, my second question, between FIST and Ottawa scale, which one do you think, sir, that can precede each other? So the reason why I'm asking this is because, when we are assessing patients, we have to put time in consideration too. So in picking one out of these, can we say that we should pick either of them based on the present status or present condition of patient, sir?
okay. Okay. Thank you for the question. Uh, Let me start with the first question, the issue of the elderly, right? Now, if you look at under Ottawa, I said the uniqueness is it's focused only on sitting balance, and it can assess sitting in non-ambulant patients. That is for Ottawa only. These are unique because that is why I brought it out as the uniqueness of the scale. So this is applicable to Ottawa alone. That is exclusively focusing on sitting balance, and then you can assess sitting balance on non-ambulant. So these are specific uniqueness of Ottawa. That is first. We shall see the specific uniqueness of FITS at the end of it also. Is that clear? That one.
Yes, sir. Yes, sir.
Second one, when you talk about elderly, you usually see at the beginning of my slide, I will say target population. If you look at a tower, I say stroke survivors, essentially at acute phase. I say individual with Parkinson's. Is that clear? Now, why I always try to put these two it's not that this scale may not be used for other population. For example, maybe multiple sclerosis, maybe Alzheimer's disease, maybe elderly individuals that are frail. But because remember, the whole title of our workshop is balance in stroke and Parkinson. That is why I'm emphasizing on this. However, it's possible this scale may be used in elderly individuals, but I cannot say because I did not really research or it is used, or I did not concentrate to find out how it is used in elderly individuals. But because maybe you have a particular interest for elderly individuals, now it's just for you to search online. Okay, what is the reliability and validity of Ottawa sitting scale in elderly or older individuals? So if you check, if once you see a literature that a study has been conducted and this scale has been validated for use in elderly individual, you go ahead and use it. That is just what you just require.
Thank you so much. Wow. Yeah.
So the last question concerning which one precede which, I think at the end of my slide, I have a slide that I made as a quick summary of if a clinician is interested in so, this is what he should go for. So we have not yet reached that scale.
Okay.
But to answer just quickly to your question, which scale precede which, at a time, it depends on your interest. That is what I kept saying. If your interest is, for example, we say this scale is designed for sitting balance. So mostly, suddenly, is targeting sitting balance. So if your interest is only to target sitting balance for your patient or for your client, then you go for the Ottawa. However, we said the function in sitting test is not only for sitting balance, but it has other advantages that it can take care of, or it can evaluate proactive, reactive state, steady state, and other balance-related elements. So if your interest is not only to assess only sitting balance, but you want to go far and also see this related component, you could go ahead. When I move to the next slide, you could see the uniqueness of fist. So when you see the uniqueness of fist, that will also help in giving you answer to your question. The question you asked, the last one, you get the answer as we move into the presentation. Thank you.
Thank you so much, sir. Thank you.
So, these are the items for fist. I think we've discussed the instruction. There are 14 items. Now, apart from the 3 nudge items, you can see I colored them in green. I think, can you see green for from 1 to 3, right? Hello?
Yes, sir, we can see.
Yes, sir, we can see.
Okay. So, these nudge items are usually, if you check even the scale, they would say they are randomly administered. If you check the scale, the PDF scale. So they are usually ordered by difficulty. These are nudge scale. They are ordered by difficulty. We know what is nudging, right? Nudge. When you want to nudge someone. Which word do I use? Maybe you want to just.
You can explain.
Hello?
You can still explain, sir. You can throw more light.
Okay, what I'm saying, nudge is like when I want to use, they are not synonymous, but I want to just use the word for some of us that did not maybe appreciate what nudging means. Like you are pushing someone. But I'm not saying nudging is synonymous to pushing, but just like that. Just like you are trying to push or to, because I don't want to say tap. If you say tap is different from nudging. But pushing is closer to nudging, but it's not the same thing with nudging. You are trying to challenge someone balance in sitting to see how the person will react.
Is it like
clear?
a slight push?
Exactly. Minimal push or very slight push. You could use that word. Maybe. So now we say anterior notch. If you check at the scale, it says the anterior notch should be given at the superior aspect of the sternum. We know where the sternum of an individual is, the area, the anatomical area. So a clinician is expected to give an anterior notch. That's like a small push to the individual. That's from the anterior part, from the anterior aspect. It's clear?
Yes, sir.
Okay. Just like you want to push someone back, like you are pushing someone back while he's sitting. But this time around, it's no pushing. You just use the finger or the hand to above the sternum and then nudge. And now observe the reaction of the stroke survivor or of the patient. Then, in posterior nudge, is that the individual or the therapist is supposed to nudge between scapula and the spine. That area, so this one is from the back. It's supposed to be from the back, the nudging. Is that clear? Then the lateral nudge is individual is supposed to give a slight push on the dominant side or on the stronger side of the individual. Is that clear?
Yes, sir.
So these are called nudge. So why I said this, I colored these nudges in green is that in some places, when they are testing, in sitting tests, they don't include these 3 nudges in the item. They will see that they will say it's an 11-point scale. And in some places, it will be, you will see that it will say it is 14-item scale. But originally, it's supposed to be 14. However, some people just start from static sitting downward, not really giving these nudges a scope. So I want to really emphasize on this. That is why I colored this. Secondly, is because in the instruction, remember we discussed in the previous slide that individual should be explained, or the patient should be informed or instructed of what to expect. So part of the instruction that a clinician is expected to give to the patient or information to give to the patient is that please be informed that at a point I'm going to give you a particular nudge, so I'm going to push you small from the front, from the back, and from the side, so that the person will know that, so that you will not take the patient unaware when you are trying to perform such act or task. So the patient should be made to aware of this thing up initio before starting the task. Because this, you remember we said everything shall be done once without repetition or second trial. So another way that we shall be able to understand why these nudges are important is because you remember when we discuss reactive, proactive balance in our previous lectures, those like when we are trying to discuss and say the ability of what? When we say reactive balance, can we remember? Reactive, proactive balance, because I am trying to link something here together. Can we remember? Reactive balance, proactive balance. Anybody that can remember? Anybody that can help? Okay, I should help myself. So, remember we said reactive balance is the capacity or the ability to regain a stable position or posture after an unanticipated loss of balance. You remember that?
Yes, sir.
So you look at this nudge. That is why it said in the instruction, the nodes are supposed to be given randomly. So that the patient will not know whether you are giving him or her anterior, posterior, or lateral node. You, the clinician, chose to administer them at randomly with suggestion for you to do them in an order of difficulty. So that is to say, once you perform that nudge, small push for the patient, reactive is the ability of an individual to regain a stable position after that unanticipated loss of balance. So that is to say, if the patient can be able to regain or to restore, so that is an element of reactive balance. And that is why we said FIST has that peculiarity and uniqueness of testing a reactive balance element, of which, if you look at the other scale, do not have such ability. Both the two scales we discussed previously, the TCP and the Ottawa. Secondly, also we say proactive balance is the ability to counteract or to activate balance controlling muscles in the trunk and leg prior to possible unstable voluntary action. So this one has to do with unstable voluntary action. So this one, for this proactive, we shall be able to see it when we come to scooting, the last three items. There, we shall be able to see how a stroke survivor, because here a stroke survivor is the one doing the scooting, him or herself. That is why here we said in the proactive balance, it has to do with voluntary actions. The individual or the patient is doing it themselves. So in the areas of this scooting and some other tasks here, you could see how we link the proactive balance to this. So that is why this test has some peculiar uniqueness that other tests do not have. So we now go to the next item, which is static sitting balance for 30 seconds. That is item 4 in some situation and item 1 in some situation, as I have explained previously. So here, the patient is expected to maintain a static sitting posture for 30 seconds without any problem. Then we look at our scoring here and see if the patient can maintain that independently for 30 seconds successfully without any issue. We give the person 4. So you assess according to these 5 items, the one that is applicable to this, the score shall be given to the patient appropriately. Then, sitting, check no, left and right. What does this mean is that the person is sitting on that chair. Remember, we said the position is that the individual is sitting on the edge of the bed with a knee and hip making 90 degrees, and then the first half, upper half of the knee of the thigh is being supported on the bed, while the other part is not, and the feet was on the floor. So what we are saying is that individual and the hand of the individual should be on his or her lap, unless if there is need for that hand to be used for support. Otherwise, the hand should be on the lap. So the individual is expected to shake his or her head, like he's saying no, like in the word no. So he shake the head from the right to left. So you now observe what the individual does. If the individual, for example, need assistance to be able to successfully shake the head from right to left, then you give 1. If the individual need upper limb, maybe he need to hold something. Maybe you need to hold a chair or a bed before you can be able to nod from left to right as a no. Then you give the person 2. Then if the person requires some cues, you need to be telling him, okay, nod your, move to the right, you move to the left, the person move, or as the person is turning the head to the right, to the left, it's taking too much time. You need an additional time for a normal, apparently healthy individual like you can do. If the person has to require extra time, but he was able to perform the nodding from the left to right, you give the person a score of 3. And then if the person can do it the way apparently healthy individual can do, then you give the person a score of 4. Then the next is sitting eyes closed for 30 seconds. So simply like the static sitting posture, but this time around there is what? There is visual input deprivation. So there's going to be a reduction in the input of visual sensation. So we observe the individual ability to maintain that sitting position for 30 seconds. The first one is with visual input, that is with eye open, while the second one is without visual input, that is with eye closed. Then you give appropriate score based on what the individual can be able to execute or to perform. Then the next task is sitting, lift foot, that is dominant side, 1 inch twice. So in that position that we've already explained, the individual is, the person is expected to lift his or her dominant foot twice, just an inch. Then, but the lifting should be twice. Then, and observe and see what appropriate score to give that individual. Then pick up objects from behind. So individual is expected to pick, to turn. Maybe you could have maybe a handkerchief or any small object placed either on the middle of the bed at the back, that the individual is not sitting on it, because we already said the individual is at the edge of the bed. So definitely there is a space between the back of the individual and the other end of the bed. So there can be an object there. So the individual is expected to pick that object. Usually the length or the breadth should be a hand breadth. Then so object should be placed there, and then the individual should pick that object and then bring it forward. This one, this posterior work is a work of copy and paste. You know, it's the previous slide of last week I used to do this slide. So maybe I forgot to claim it. So assume as if you didn't see it. This posterior work. This is part of ABC scale, please. It's not part of scale. You can see question mark. So next is forward reach. So here, individual is expected to use a dominant arm to complete a full motion of reach. That is to say, this individual is sitting the way you see on the edge of the bed, just pull, like how it's done in functional reach test. The individual push his or her upper limb straight forward and complete motion, and you observe the individual. Also, this walk across is not part of it, it's part of ABC. I'm sorry for the inconvenience. Then, lateral reach. This part, individual uses the dominant arm to try to reach opposite the axial tuberosity, that is to reach away from the body, from the midline, to reach. Instead of just like reaching forward, this time around the individual stretch his or her upper limb and reach laterally away from the body. And there is also expected to have a complete motion. Then the next task is picking an object from the floor. So there should be an object placed between the 2 feet. So as the individual is expected to flex the trunk and pick that object from the floor. So the individual, as he does that, he observe how he does it, and then see the appropriate score you could allocate based on the performance of such task. Then posterior speed scooting. So we know what is scooting, right? Scooting. Hello? Scooting, do we know what is scooting? Scooting. Okay. like you are moving, but you are in sitting. Moving in sitting. Let me just use that term. Moving in sitting. So posterior scooting is that you just move your trunk completely. You move back. So like you see that the patient is at the edge of the bed. So in posterior scooting, the patient is being asked to move backward with his or her trunk 2 inch back, and you now observe how the patient does it. Anterior scooting is that then from that position, the individual should now move and come back to his or her original position. So that's anterior scooting. The lateral scooting is an individual to move to dominant side. Move toward dominant side 2 inches away. Is that clear? So these are the items for fist and how they are being made. We shall do them practically in the practical or hands-on follow-up workshops. So so the most important thing we shall not forget here is that there shall be an instruction. Those instructions for this test must be adhered to. Then those tasks, the nudging tasks must be randomly inserted. There should be administration of the task with adequate information to the patient before giving the task. The push, so during the nudge, please, the pressure should not be too much so that the patient cannot be made to fall. So that, because that's why I try to avoid the use of the word pushing. Maybe light pressure. Can we say maybe light pressure? You give a slight pressure that will be enough to elicit a postural reaction. That is what is just required in the notch, please. And then one push is allowed for each of these anterior, posterior, and lateral notch. Is that clear?
Yes, sir. Yes, sir.
Okay, thank you. Then, this function in sitting test has an online calculator. Okay, before that, let me say this for emphasis. I think it's important. If you are doing this first, please, let me go back to the core. That is what I want to emphasize here. You see this place? This physical assistance number 1. When somebody needs assistance to complete a task without a difficulty, please, apart from giving the score of 1, one thing that is suggested and recommended for a clinician is, because we want to be as specific as possible, please try to also document the level of physical assistance given to the patient. Because it's possible patient A scored 1 on fist for a particular task. But that one, there are 3 patients one patient A may be needing only mild physical assistance. Patient B may be requiring only moderate physical assistance. And patient C may be requiring only maximal or much more physical assistance. Now, this is important because even when you are trying to compare the recovery of your patient across your patient, you should be able to be as specific as possible and know exact what the ability of that patient and the inability. Because if, for example, as a colleague clinician, pick a folder I used to check or to document or for any reason, and now maybe he's seen the patient, there is patient A in the waiting area and patient B. Maybe seeing patient A before seeing patient B. Maybe when he's checking under fist for a particular, maybe item 6 under fist, he sees that, okay, patient A scored 1 and then patient B also scored 1. So you are giving impression to the clinician that the patient had the same level in terms of such tasks. While in real sense, if patient A required mild and then patient B require maximal assistance, they are not the same. They are not at the same level. And what you can do to maybe treat and manage the patient to make him or make her regain certain level of recovery may be different, because somebody requiring minimal and somebody requiring moderate or maximal would definitely require a distinct approach or distinct level of, even if it's not distinct, but maybe the intensity, the dosage of what you apply in trying to control or to manage for that will differ across this patient. So that is why it's important for you to be able to be as specific as possible in trying to say this is the level of assistance that the patient is requiring. Another thing I forgot to mention is that this test is usually recommended that it should be performed when there is someone that is close by to the patient. Patient should not be allowed to perform this task only alone. In fact, suggestively or recommended is that even apart from the clinician, if there is somebody just close by, because this has to do with balance, and we always try as much as possible to avoid fall when we are trying to conduct or perform this test, because if falls happen, the patient will maybe losing confidence, or the patient may not give you the adequate cooperation when you want to do such type of test, because the patient may be thinking it's going to be fall all the time. So it's important to ensure that there is somebody close by in case of unexpected eventualities. The individual or the stroke survivor or the patient can be supported immediately without being allowed to fall. Now, the next thing that I'm trying to explain, I was trying to say before, is that we have what is called function in sitting test online calculator. So this really eases the work of a physiotherapist or of a physician when he's trying to perform this test. So you just enter online and say function in sitting test calculator. Is there. Function in sitting test calculator is free. Some people can just enter now with their device and see. Can we see it, please, so that I will be sure people have seen it? Can some people just check and see function in sitting test calculator? Yes. I tried to use the slide.
Function.
Hello? Can we see it, please?
Yes, we can. We can see it.
Can you see? Okay, try it. Try Just try. Let's go. Let's go to other item. Let's go to the item. Random notch. Anterior notch. Just choose an item. What is the score? Hello? Hello, I can't hear you. Who is speaking? Okay, so who is having the online with him or have this? I just want to show something. Oh, can I show it on the? I think I can show it on the system, right? It's better.
Yes, sir, it's better.
Let me show it.
Okay, sir.
Let me show it. Sharing, and then share my browser. Okay. Function in system. Best calculation. Alright. So, can we see? Let me share the calculator here. Yeah. Can we see? See it? Is it showing?
It's showing.
Yes. So you just select. For example, when we say, okay, anterior notch, maybe the patient scored 3 based on the tax performance. Then posterior notch, maybe 1. Then lateral notch, maybe 2. Then static sitting for 30 seconds, maybe the patient scored 4. Sitting shake, no, left and right, maybe 3. Sitting eyes closed, maybe 1. Sitting lifting foot, maybe the patient scored 0. Pick up object from behind, maybe scored 2. Forward reach, maybe scored 3. Just an example. Lateral reach, maybe scored 1. Pick up object from the floor, maybe scored 0. Posterior scooting, scored 1, maybe. Anterior scooting, maybe 2. Lateral scooting, maybe 2 again. Can you see? It's already giving you the score at the end. So you don't need to use your calculator. Once you have the score, as you are doing, you can be filling online and then you'll get your score automatically. Maybe you could print it and add to the folder of the patient. It's clear, right? Can I go back to my slides?
Very, very clear. You can go back to your slides, sir.
So what's the name of the calculator, sir?
Function in sitting test calculator. Just the name of the scale, you just add calculator. Okay, the slideshow is not doing. I don't know why. Is it okay like this? This is okay, right? It's showing now.
Yes, sir. Yes, sir. It's okay.
Okay, somebody said I should please recap on item 5. of the fist. So that means shaking of head. I mean, I said the individual is expected to nod, like he's saying no. Not like somebody will say no, 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 no. So the person is nodding his or her head from left to right. That is what is called, what is meant by shaking no, like as in the word no, from left to right. Okay. Then the psychometric properties now of fist. It has been validated for use in stroke patients and patients with neurologic dysfunctions. So really, this fist has been validated for a lot of neurologic because it's, I saw some literature that says it can be used for neurologic dysfunction. So you can see that it's not only limited to only maybe stroke and Parkinson's disease. Maybe it could be used for multiple sclerosis, other neurologic dysfunction. So next is that it's also been found to be reliable for stroke and other neurologic function. Now, the uniqueness for it is that it assesses all the components of sitting balance. Because you can see, we said it can assess reactive, proactive, steady state, post-sensory, motor, all those elements related to balance. It has the ability to assess it. So this is the uniqueness to it. So while it still assesses balance as for tower, but it has maybe some advantages over Ottawa in the sense that it can assess all the components of balance. But Ottawa may not be able to capture all the components of sitting balance as fist can do. Also, clearly the literature has shown that this test is useful both in research and also in clinical practice. So, what I also want to add here is that in trying to carry out these tests, usually the precautionary measures are really vital, because in a situation whereby the test can be performed without precaution, is, I don't want to say calling for anarchy, but it's not advisable. It's not too much to keep emphasizing on the need to have a precautionary measures, especially in performance measures. You know, we have scale that are performance based, that there has to be execution of tasks. Then we have some scale that are maybe questionnaire based. You just ask questions and then you fill. So especially the scales that are performance based, it's really very important to have those instruction and demonstration before the patient is being allowed to carry out any task. So also the standard positioning and the requirement expected must be strictly adhered and followed to. Otherwise, if that is also not followed, there is likelihood that errors are going to arise from doing the test, because it's what is being carried out with deficient or with requirements that are incomplete or that are unsuitable for the performance of the test. As such, all the readings that an individual will be getting may be readings that are going to be what? That are going to be wrong. So therefore, having those requirements set and then follow in the guidelines or the instruction for the scale appropriately is a key in executing the task. Also, the scale, apart from using it in stroke, even in vestibular disorders, that is in disorders that have to do with lack of balance related to maybe vestibular component of the body, ear component, and the likes. This scale has been shown to also be used in those type of individual having such types of dysfunctions or disorder. So in essence, it's a scale that is a test that can among these three scales. This test is one of the most widely that has a wider application. That is the population that can be used for this test. They are wide. The populations are wide. Aside others, which we discussed the first two, it has more wider application. So when you are trying to put them side by side and see, okay, what are the distinct differences, you could see that this scale, the fits or the test, has more wider application than the Ottawa. And you could see likely, based on what we discussed, Ottawa also could be said to have maybe a little bit more wider application than TCT. So that is how the two scales are side by side when you try to compare the two. Then I have this, okay, take home. I say this is take home or take clinic message. I said if a clinician is interested in trunk control and trunk movement evaluation in stroke and others, then the clinician should go for TCT. So that is what I'm saying. I have a summary here. If you want trunk regulation or control and movement assessment in stroke and others, then you go for TCT. That is trunk control test. However, when you are interested in assessing sitting balance, just sitting balance in the acute phase of stroke, Parkinson's disease, or in non-ambulant patients, you go for Ottawa sitting scale. In a situation whereby you want to assess all the components of balance and related elements, not only sitting balance, but you want complete component of sitting. You are interested in everything related to sitting. Stroke, vestibular dysfunction, or other neurologic dysfunction. Then you go for fist. All these skills were specifically implied or pointed that they are very useful in both practice, that is in both clinic and then in research. So in essence, the literature is categorically clear that these skills are so germane in both clinical practice and then in academic practice or in research practice. So in clinical practice, it's telling us that these skills can be used always to either track the recovery of our patient and see the outcome of our rehabilitation or the outcome of our care. And it will also, and there are also important skills that we could use to set a limit or to see what is the level, at which level is our patient is, or at which level our patient is. That is either
Sir, we can't see your slide though.
Hello?
We can't see the slide being discussed.
Oh. Well, nobody's saying. Sorry. Let me reshare. I'm sorry. What of now? Can we see the slide now?
Yes, now it's showing.
It's showing, right? Can you see
Yes.
what I'm posting? So from where did you stop seeing the slide?
It's showing, sir.
Please put it in presentation mode, sir.
Okay. Is it showing?
Yes, it's showing. It's showing.
Okay. So can you see what I'm saying? that if a clinician is interested in trunk control and trunk movement in stroke and others, just want to know how trunk control is. If not interested in sitting, to know whether the patient just control of the trunk, then TCT is enough. But if a clinician wants to know the extent of the sitting balance of his or her patient, then the clinician can go for Ottawa sitting scale. However, in a situation where the clinician is interested in, not only the balance in sitting, but all components related to balance. Maybe the clinician is interested in aspects such as reactive, proactive, all those elements, sitting, sensory motor, and other.
Excuse me, sir. Can you check the slides? It's like two slides are showing at the same time. We need it to be bolder so that we can see. Some of us are using handset.
Okay, sorry.
Thank you.
Don't know what is happening to this man. Yeah. Right. Still two, right? I'm coming.
We're just seeing a blank screen.
Just 1 minute.
Okay.
Okay. Okay now.
Okay, yes, now it's better. Thank you.
So you can see it, right? I think it's, when I try to put it into presentation mode, it's scattered. I don't know why.
Let's use it like this. It's better than the other one.
So you can see what I'm saying. So if the person is interested in, okay, I want to know, I want to go in depth into the sitting balance. I want to know not only at maybe gross sitting. I want to know the specific, the component of sitting balance. How is this patient doing? What is the patient doing well in this aspect, in the reactive, proactive, in this component, or just as broadly as possible, and also as specific as possible? Then the person can go to peace. Then I said they can be used both in clinical and then academic practice or research. I was explaining that in clinical research or in clinical practice, you could use it to track the progress of your care to the patient. That's the care and clinician we are giving to our patient. We can track it at a particular level. For example, this is important because if you look at these scales, most of them, or all of them, we say we produce them as soon as we are in contact with our patient, even from day one in the ward, even in the acute stroke unit, even before being transferred to the ward. I said, once we can get stability in the patient, we can try to, because without using these things, is we might not be able to really boldly come out and say, quantify what we are doing and see the result. So but by the time we start to use these measures, even from our acute stroke unit to the ward, to the time that the patient will be recovered, will be discharged, and then start coming for outpatient rehabilitation, that will go a long way in really showing what is the progress we've made, how the care is moving from one stage to another. The most important thing here I want to point out is that I know that maybe in the ward, usually in our wards, we usually use the folder, the inpatient folder, and then maybe by the time patient is being discharged, we have another separate folder in our physio clinics. So, but because these measures that we are doing, the best thing we could use is for us to be documenting the scores of the individual in our case folders, and then also, if possible, to even insert the copy of the scale that we use for the patient in the case folder. So I don't know in our hospital how we could use it, maybe, since we are having for us to track, because if you say we are tracking, we need to know what happened from the beginning. So I don't know, is it possible? I think it's possible for us to retrieve a folder of a patient, even if the patient has been discharged from the ward and is coming to outpatient. That is one way. And then another way, maybe by the time there is an electronic means of record keeping, that may make it easier. Even if anywhere in the world, maybe there is a place that the therapist can document the finding, and that finding can be shared locally within the hospital. I think something like that. We be able to track, because if we say we are tracking, our tracking should not be limited to when the patient starts outpatient, but it should be from the time the patient is being seen in the ward. Because this aspect, a lot of factors you will have will tell you, you can be able to predict what the patient can get in terms of functional recovery if you can properly do this assessment at the acute phase when the patient is on bed in the ward. And that will truly be able to give you confidence and then opportunity or information to discuss with your patient and then detail to him or her that, okay, this is what you expect in the recovery, this is the prognosis, and this is the timeline. It will even guide you. You also set timelines in terms of, because what you get will serve as a predictor of what you are likely to get after the end of the rehabilitation of the patient, which is really very important when you do it in such manner. That is in terms of tracking the recovery of your patient. Even apart from tracking the recovery of the patient, even to know the extent or the level of the ability of the patient is also important, because even if, for example, you are not maybe tracking, maybe at a time, maybe the patient is being seen in the particular hospital A, in the ward there, but on discharge, the patient is going to be doing rehabilitation in another hospital, maybe based on proximity or for any other reason. That the patient chose to do outpatient physio somewhere, not in the same hospital that the patient was admitted, then you could have maybe in your referral to the physio in the other hospital that the patient is going to start outpatient, is going to be beautiful for you to document, to detail to the physiotherapist that this is the extent of the tone control of the sitting balance. So in that instance, you are not really per se taking the measurement to track, because you are not going to continue the management, but rather saying this is the level at which the patient left the place or left the inpatient place of your center, and the extent of the maybe sitting postural control or sitting balance and the likes are, and then the clinician there can take it up from there and down in his own case can be a source of tracking the extent of of how the care, as he gives the care, he keep checking to see. So this is why I think it's important in tracking and knowing the extent of or the level. And then in research environment, it can also be used, because you can use this scale. Okay, maybe you want to do a 12 weeks or a 3 months research of balance training or sitting balance training, a particular protocol. So at the beginning, maybe you measure fist, or you use for tower, or you use CCT and see the level, the baseline value. Then you administer treatment for rehabilitation for 3 weeks or 6 weeks, 12 weeks, depending. And then you now major maybe after 2 weeks or after 3 weeks, and then maybe after 6 weeks, and then maybe at the end of the intervention, maybe at follow up, depending. So it depends. So that made it a very important component for outcome to be used in research practice. Also, in research practice, these skills, like for example, the 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 Ottawa sitting scale, you can use it to some of them can be cross culturally adapted to a particular, for example, settings that maybe it has not been developed before, or you could try to see, okay, can we adopt it or modify it in a particular to suit a particular setting? It's also possible. So that's also made it to be an important component in rehabilitation or in research practice and the like. So there are a lot of things you could use to really make this skill very usable, and it will really impact in the patient management. One last thing I should be able to say is that, especially with the FIST, that's the function in sitting test, it has very variable clinical use, including it can, apart from even, we said that it has ability to check balance component and various balance elements, related elements. It also has that ability to know what is the real functional ability in sitting. It also assess or evaluate lower level patients, especially if other tests will be too difficult for patients to carry out. So it has that also indicating that patients that are lower level, those that have difficulty in executing tasks, that may face difficulties executing particular tasks, it can be allowed the patient to be able to do. And it also focus on interventions. Many interventions that can be used for balance can be, it focuses on that. Also, many patients, as I said, it has a lot of application in many population groups. However, this scale is most suitable and best suited for patients who can obey command. That's someone who can follow instruction. Or you are suspecting a deficit or a dysfunction in their sitting balance, or they have problem with safety. That they have safety issues in their balance. Maybe they have poor seated postural control. So these are all areas that when you have in your patient, you will be looking at, okay, FIST will be a better suited to be used than maybe any other type of scale. So from this, to the next slide. So this is my conclusion slide. I said assessment of strong control, strong movement, sitting balance, and seated postural control, as well as characterizing sitting balance and related elements, can be effectively performed with the three scales, that is the strong control test, Ottawa scale, functional function in sitting test, during the application of patient stroke and Parkinson, among others. That is to say, and even other neurological functions by extension. So thank you very much. And we can now open it for discussion. Any other? So the floor is open.
Hello, sir. Thank you very much, sir. Can you hear me?
Yes, I can.
Okay. Thank you so much, sir, for this wonderful lecture. Please, I need to get a bit something clear. I'm not sure I heard that very well. Network was somehow when you were speaking. You said a particular measure could be used for patients who, you say, not following commands. I mean, those who are not very articulate. There are a class of patients who really are not very, very good with instruction, especially the elderly. Some of them with this stroke, they're not able to. You can just do what you want to do, get them standing when they are ready for that. Occasionally, you can ask them to do some resisted exercises and they obey. But then on a very, very general note, they are not that articulate in terms of taking all instruction. But if you sit them up, they are able to maintain balance occasionally. So I don't know if that's what you mean by people who are not able to. I mean, which of the outcome measure are you referring to for such
Yes,
class of individuals?
yes, I'm trying to talk about the fifth, the last one. But what I'm just
Okay,
saying
okay.
is that it's best suited for. We are not saying you cannot use them. That is why one of the thing I kept emphasizing is for they need to have someone close by when you are performing the task. So in as much as the individual can obey certain commands to some extent, then fine. The only thing is that once if the individual cannot obey command maybe because of cognitive difficulties, then the maybe if the text cannot be carried out, then maybe that is understandable, unless maybe the cognitive function has improved. But if at all there are some level of instance, we can follow certain level of instruction. It's not because why the fist is very the command following command is very important in fist is you can see almost all the tasks you can see is asking somebody to do something. Apart from the first three nudges, maybe the starting sitting, you ask the person to sit for 30 seconds. You ask the person to shake head, asking no. You ask him to close the eye while sitting. You ask the person to lift foot, to pick object. You see, to reach forward, to reach laterally, to pick object also from the floor, to scoot posteriorly, anteriorly, and laterally. You can see a lot. Most of the items you have to ask him to or her to do something. So that is why it's saying that it's really best suited for individuals that can follow simple instruction or verbal and non-verbal command. I don't know whether it's clear.
Okay, so that's fine. I think you just emphasize that. So it's for those who can follow instruction, but there is none for those who cannot follow instruction. Okay? Because I don't
Okay.
know, I've encountered a few clients where you basically have to help them out. Some of them in
Okay.
their 70s, they can do these things when they are willing to, or when at that particular moment when you want to assess
Not
that
even
function.
they will not do it. But is it because of cognitive problem or what?
Yeah, we say partly cognitive, but someone who might decide when not to open his mouth to eat, when to stand. He stands on his own when he wants, but when you're asking him to stand, he doesn't want to stand. You're asking him to move his hand and he's being resistant. There are actually some difficult cases like that where patients are not willing to respond to instruction due to either mood swings or stuff like that. And but you can see there are some abilities in them because when they are willing to do this, they do it. But then on another situation, I don't know. Those are some of the outliers in these instances where
The
patients don't
challenges.
really. Yeah.
But the issue here is that so if somebody has those cognitive issues, not even obeying command, it means if you are using a questionnaire scale, maybe the person will not answer the question correctly. If you ask the person questions, maybe you will reduce the answer. how do you use the answer? I don't know whether you get what I'm saying. Even not only apart from the performance, even
Yes, sir.
the
For some of us in the clinic, we've seen different things. They are patients, most stroke patients, some of them are not expressive. Some of them won't talk. They are getting speech therapists to work with them. Speech therapists are
oh
getting frustrated because patient decides the day he wants to talk and the day he doesn't want to talk. They bring pictures and patient decide who to identify and who not to identify. You bring food, the patient decide which day to eat and which time not. I don't know, but like I said, some of these outcome measures might not really be applicable to them. I'm just like, because I think I
yes,
overheard you say something about one of the outcome measures could be used for people who do not obey command. I thought I heard that. That's why I wanted to clarify if there is any such provision. But I think you're clear when you with the explanation of the thing. I think it's okay, no problem. Thank you.
Hello, sir. Can I contribute, sir?
yes,
All right, sir. My brother that just spoke now is actually correct because I deal with some category of patient like that. But in that scenario, I will call it non-engaging patient. So it's not that they have cognitive issue, it's just that they are not engaging well with physiotherapy. So for patient with cognitive issue, we cannot categorically say that we should rule them out of this assessment. So, for my own opinion, I think so far they can obey simple instructions. They are fit to actually perform this test. So, I think this particular one is actually different from non-engaging patients. So, non-engaging patient is different from patient with cognitive issues. So far they even have cognitive impairments, they can actually still benefit from this assessment based on one condition if they can still obey simple instructions. So we just have to make our instruction to be simple and clear for them to obey.
yes.
That's what I want to add, sir.
I think what you are
Thank
trying to say is
thank
that
you.
some
Yeah.
patients just need more engagement to be able
Yes,
to.
yes. So yes, I work with like that's the category of patient I work with now. So there are some times that they don't engage. It's not actually that they have cognitive problem. So just that they are just moody. It might be as a result of depression or mood or whatever. So I think that one is different from patient that is being confirmed or being assessed of having cognitive impairment. So when patient is being confirmed of having cognitive impairment, so we can actually still use this based on the level of their cognitive impairment. So, and this one is different from non-engaging patients due to maybe depression or mood or whatever.
Yes, I understand what you are saying. What you are simply saying is that there are two categories. There are
Yes,
non-engaging patients. There are patients typically with cognitive issues. So we need
exactly.
to
Yes,
differentiate when we are dealing with a patient whether we are dealing with somebody who is having cognitive issues, then we know, or
yes,
we are dealing with somebody who is non-engaging. So we need to engage that person more to get tested.
yes, exactly.
Thank you.
Yeah, thank you. That's a valid opinion. Thank you.
Any other addition, subtraction, comment, question? Okay. No comments? No question? No addition, no subtraction? Okay. So can you please give me 2 minutes? Let me communicate with the second person to know so that we know how many minutes we are taking break. Let me know when he's starting so that I can respond.
Okay, sir.
So we will be having the follow-up workshops for the practicals and hands-on by the time we finish today's one. We will now see how we can now do the practicals and then the hands-on. And the arrangement is that we want to have the hands-on to be like regional if possible. That we might likely have it some maybe across the geopolitical zones, depending on the number of participants we have interested in that hands-on in that zone. So it could be if we have a certain number, if we have that number up to that number, then we have the facilitator designated for that center. Then that person can coordinate and do the practicals in that center. Then if you don't have that number, we have to collapse and then choose a particular center that is a middle ground for a particular zone or area to have the hands-on workshop in those areas. That's the plan. And then we also have the one on management. But I think it's good we finish the assessment first. Please remember that we said it's important you try this in your clinics. That is why we give this week's interval, so that by the time we discuss outcomes or skills, you can be able to now put it into practice with your client and patient. Because sometimes it's not even about this our discussion here, theory. When you go to the field, you see the real some practical challenges which we may want to discuss with colleagues. And this avenue of workshops and avenue where there are very senior people that have been using maybe the skills previously, the challenge you encountered, they have encountered it, maybe they know how to solve it. And there are a lot of people who can brainstorm ideas, evidence-based ideas, and see how we can progress the management. So I think it's important we try to, even if we cannot be able to apply all the skills, because we can pick some and try to use it maybe before the answer, so that it become an easy way for us to be using them. Because sometimes just keeping the theory, it might not really help us. Yes. But when we are using the skills, that's why I try to say, let's be sharing the skills so that people will have it maybe as soon as the workshop is over, the individuals can begin to apply those in their usual daily practice. And the aim at least for us is through patient care. So if we can have that, it will really go enough in improving the care of our patients, improving our confidence, also improving the patient's confidence. Really important. Are we okay with the plan for the practicals? I think it's fine, right? Or you have other opinions? Hello? Hello, can you hear me?
Yes, sir. We can hear you.
Oh, so I
No,
was
no.
afraid.
In my own
I hope
opinion, maybe you can just have. Hello, sir.
yes, I can hear you.
Yeah, in my own opinion, I'm thinking maybe a central hands-on would do, where maybe from we have a model somewhere, say for instance in Kano at the clinic, and then clinician demonstrates what what we have to do. Then I don't know, because asking people to gather someplace sometimes I'm not usually feasible.
Oh,
That's what I think.
you mean the thing to be transmitted online?
Yes, unless
Yes, you could have that. You could have that, but you know the aim is for us to have people to do it practically themselves, and you know there's difference if you have it transmitted online. Yes, you could have hybrid. That's why you could see in our calendar we say hybrid.
okay.
So, for example, if you can be doing it and then streaming it live, you
Yes,
understand?
yes.
So what you are saying is that some are having physical attendance, some are having virtual attendance.
Okay. Yes.
You understand? I understand what you are saying. Yeah, that is also a possible thing. Yes, we will explore all the options and see how we can. Okay, very poor audio. You can't hear me.
All right. That's fine. Thank you.
Yes, we will explore all the options. Somebody said, what can we do to make sure many physiotherapists know about Ray Institute? Wow. I think it's a general question, not only the. I think it's publicity. Maybe you are trying to say we should increase our publicity. Ademola, please. What do you really want to say? Lajide. I think it's Olajide, if I'm correct. So this is important question. I really need to know what, because I think physiotherapists know, but maybe there is a point he wants to make. Okay. Maybe it's
I
not
have a
close.
suggestion, Sha. Hello, sir.
Okay. Yes.
Okay. Thank you for the wonderful presentation. So I think that question to make awareness, that's the most publicity. I think that one could actually help because what I do is because many people are not really aware of Ray Institute. I'm not based in Nigeria anyway, let me call it in that way. So many people wanted to have the CPD, something like this, but they are not really aware how to get that. So what I do is I send the available your advert, I send it to them. So I will ask them to, if they are able to meet up that particular day, I will ask them to pay. So from your own end, sir, I'm thinking anybody that join your workshop or whatever, I think you try as much as possible to keep their number or keep their details for the subsequent maybe for the subsequent updates. So by doing that, they too, if they have any other person, they can send that invite to another person. With that, our number will be increasing.
Okay. Thank you. Yes, thank you a lot. I think we do that because usually we have all the workshops we have been doing for the past years. Each workshop we have a WhatsApp group. And every time we are sending for a workshop, a flyer, we send to all those groups. So I think that also helps with that. Okay, somebody says those of us should invite others. I have introduced some junior colleagues. Yes, correct. Many don't know.
Yeah, so
I'm not through that fact.
yes, hello, sir.
Yes.
Yeah,
Yes,
that's a valid one. Of course, like you just said, I can say that I've practically been in majority of the workshops. So most times when they are sharing
I think I
flyers
can
for a
even
new
say I
workshop,
can say all.
yes. So anytime they are sharing flyers, my WhatsApp is filled up with a
Still, yes.
long list of yeah. So
Exactly.
so that's what happens. And for me, some of them are it's really something I think people need to know more about. Maybe again at the level of the board, in as much as we don't want it to look like because the CEO is part of Ray that is taking, but I think at the level of the board where people are struggling to meet up with CPDs, I think they should also have an idea because I believe that for every workshop that has a CPD attached, I believe the board usually gives an approval for it. So meaning the board should have a list of all the accredited
CPD
workshop
providers.
organizers, yes, so that they can also help those who have struggled meeting up with their CPD points. And this is not
For
even
those,
just for physiotherapists
for,
alone,
yeah,
maybe the
yeah.
prosthetics and other teams, so both should have those
A
lists.
list.
Make just yeah, just make a suggestion to them to say we know these people organize this and these people organize this. You can have a number of a contact person just for those so that because part of the challenge we used to have before it came up is situation where we didn't have opportunities at all. But now Ray has made it in such a way that every week you have a seminar. Let's just say in a month, apart from the festive periods, where for some reason or the other, 1 week or 2 weeks, like if it's Christmas or Salah or some big celebration, they just give people off that period. Otherwise, in every month there are always minimum of 2 workshops. So I think for those who are struggling to get these opportunities, it should be if someone should have it. Well, of course, I've also invited persons individually, but that's still not going to be enough. So
Yeah,
I think if there are people who still find it difficult meeting up, sometimes I have all over 60 CPD points, if more, as much as is possible I get, and it doesn't change anything. It's only increasing my knowledge base of all of these things, and it helps my practice. So, and I think it's something we should avail to every person who is really interested in upgrading their knowledge for
yeah,
the upliftment of our profession. Thank you very
yeah.
much.
Thank you so much. Yeah.
Hello, sir.
Hello.
Good
Yes,
Hello,
morning.
sir.
yes, yes,
Yes.
yes.
So
Yes,
concerning
sir.
the publicity for this program, I also think maybe Ray should also look at because I know MRTB is organizing a particular program at this particular time now, and we have some members also who are doing that particular program as we speak now. Because
I think
I
even
actually had
NSP
to
has a workshop today. NSP
yes.
also.
Yes, I'm aware of that. So I had to choose, and I think it's also 3,500 as well. So I think some people will even know about it. So possibly, maybe anytime MRTB is trying to organize a program, if it's possible, Ray can shift their own program to Wednesdays or Saturdays because as we speak today now, MRTB is organizing a program, and I think they are also giving points as well. So maybe it's part of the reason why some of these things may occur at
Yeah.
times. Thank you.
Okay, I understand. Yeah, it makes sense.
Yeah, so let me add to what he just said. I was
Okay.
also tempted, but really, I don't play with any opportunity to add knowledge, no matter how little, even if I something I know.
Yeah.
So what Aurora just said now, I would have paid for that, but there's no way you can attend two workshops at the same time,
Workshop.
and they are both online.
Exactly. Exactly.
the only thing that would have happened is if I'm on the group and they share the Zoom link at the end of the day, and it's difficult to go and replay this. How can you play a whole day seminar or workshop? Which day do you want to play it? Is it that we don't have any other work to do? So most times, even the Zoom link, it's difficult to go back to it. That's for me, honestly. So as much as you could gather, because we still have to do things. It's not as if every Saturday we just come sleeping or lying down in the house. As much as you could gather, like most times the afternoon segment, by the time they start, it's either you're not able to log in or you're now got so busy that you're not able. But what I'm saying is, what he just said is right. Let them not clash these things as much as it's possible, so that people also, but also you can also leave it open. Those people can
Yeah.
choose what they want. You can say, okay, I
Yes.
prefer this over that,
Yes.
and then you go for it. I don't think
Exactly.
it's something that is deliberated on. People should also
Yeah.
have an option of choosing what they prefer. Thank you.
Yeah. Because the problem sometimes you say you want to avoid clash. Like for us in Ray, we have the whole year calendar. So it might be difficult for us to say, okay, we don't know when others are organizing. And we don't really meet to say, okay, so our own, we know every year we have a calendar for the whole year. So and we do it, it doesn't matter whether it's 10 people or 5 people or 20, we do because we follow the calendar. So that's how it is.
Hello, sir.
Yes.
Good afternoon. Thank you very much for the wonderful presentation.
Thank you.
Please, I have a suggestion concerning the publicity.
Okay. Thank you.
I think it's better we create a general group, Telegram group for everybody. In the sense that anybody that graduates from physiotherapy on the day of induction, we join that group. So if we do that, and all the HODs of the hospital units will join, we advise the interns to join and the workers. In the sense, doing that if a workshop is going on and which I know is approved by the board, then the flyer will be shared in the platform. It will be easy to get to everybody.
Yeah.
I think I'm just suggesting because I know some professionals they have that.
So
I don't know.
You mean the Telegram is now is it for Ray Telegram or who?
No,
That's
it's
the
not for Ray. If you can, it's not for Ray. If you can talk to the board, that the whole therapy in Nigeria should have a general that we can pass information. So once the board give approval for workshop, they can post it there. So no matter where you can have access to it. Even the ones that are graduating, that recently graduated, that are doing internship, they can have access to it. Some of them don't know about this thing.
Since Telegram can carry a lot of people, so everybody can.
Yes, sir. Yes, sir.
Thank you so much.
Thank you, sir.
Yes. So thank you so much for the suggestions. Let me check. Okay, somebody wrote that like especially for the diaspora, we should improve the use of technology to enhance the quality of the training. We shall do that. Thank you for the suggestion. I think in the absence of any other comment, the facilitators just communicated to me that he will be starting at 2 p.m. So we have a long break, almost over an hour. Yeah. So we can reconvene at 2 o'clock, please. Yes. Thank you all for participating.
Okay, thank you, sir.
Yeah.
Thank you so much, sir.
Yeah.
amma wanda yake da suga Allah
Sir, no audio, please.
Good afternoon. Sorry, I have not commenced yet. I'm just trying to share the slide. Sorry. Good afternoon, everyone.
Good afternoon, sir.
No, sir.
Yeah, sorry about the delay in the take-up. Can we all see the slides?
Yes, sir.
Okay. It's now on a slideshow. Is it also visible?
It's
Is it
okay,
still
sir.
visible? Okay.
Yes, sir. It's okay.
Good afternoon once again. Good afternoon, everyone. And sorry for the delay again. Yes. I'm here for the second session on the topic that commenced earlier in the morning by my colleague, Dr. Jibrin Samani, which is on trunk assessment. Yes, and like similar to last week, I was also online listening to his presentation, and I would say he has done justice to the topic. He has said a lot about trunk assessment, and he has taken some important assessment tools of trunk. So this presentation is just going to be an augmentation, yes, to just a few additions to what he presented earlier in the morning. Yes. After the introductory aspect of the presentation, I will be taking two instruments or two trunk assessment tools, which is functional reach test, which I skipped last week in the presentation, which I said is going to be part of the trunk assessment. Then the trunk impairment scale also. So by God's grace, today we'll be taking these two instruments. And I hope by the end of the presentation, we'll have addition to, and also not necessarily new, but addition to what because we already know these things. It's just for us to discuss it maybe at detail level and at length, and to also see the possibility of how our discussion today will impact on our patient management. Of course, because when we have a very good assessment, a very good evaluation of patient, that will translate to our management, because through this instrument is when we'll be able to know how much of change has occurred in this particular patient of ours in the clinic. Without the use of this instrument, we won't know how much of problem is there. And after our treatment, we don't know how much of improvement we have added to the patient, whether the treatment we're doing is the right treatment, whether we need to change it or we need to modify it to suit the particular level of impairment of that patient or individual. So by way of introduction, what is trunk, first of all? Trunk, it has a lot of variation. Depends on the angle of where the individuals are looking from. For example, in other specialization, they just look at trunk from shoulders or just below the neck down to the back. But in our own aspect or in our own topic of discussion today, we're going beyond that extension, which is pelvis, which is also included as part of the trunk. So either way, we can look at it that the trunk it comprises the thorax and the abdomen and the pelvis, or we say upper trunk, that's the thorax, lower trunk, that's the pelvis. Some classify also the mid-trunk, but in most of our discussion, in most of our assessment, what we're looking at is upper trunk, lower trunk, two divisions of the trunk instead of three. Anatomically, in many other, like I said, it depends on the point of view, or it depends on the angle of the practitioners or the clinicians. Yes, but what we have, or what we're looking at is upper trunk, lower trunk, and that upper trunk is the thorax, the chest, then the pelvis as the lower trunk. Then before we go into assessment, this trunk will be, as we'll be talking about, there are many components, or there are many things that constitute the trunk. Yes, apart from the bony components that we just mentioned, or things that has to do with what the part of the trunk consists. For example, we say abdomen, we know that yes, there are abdominal structures, the stomach, the internal organs, and many other things. We talk about the trunk, I mean the thorax, we talk about the lungs, the mediastinum, the contents, that the heart, the esophagus, and many other things. Then we also have to talk about the muscles, because that's where we are primarily concerned here. When we talk about the posture, control, balance of trunk, primarily we are referring to the muscles, of course, plus other components. Yes. So these muscles are those which support the spine, the hip, the pelvis. That's the lumbo-pelvic hip complex, of course, that we know. However, yes, these are just examples of the muscles: the internal, external obliques, the erector spinae, the semispinalis, multifidus, psoas major, quadratus lumborum, the rotators, and many of them. These are just examples of just a few of them that I just mentioned. But in our own situation today, sorry for taking us back about trunk muscles, part of trunks. I just want to lay some foundation. Then we go further to look at the assessment. Then, yes, not just specifically the trunk muscle we're talking about, even the upper limb and lower limb muscles also by extension act on the trunk. Example, the pectoralis major, latissimus, gluteus, hamstring, and so on. Then the upper trunk, which is not usually talked about most, is yes, the thorax, the scapular aspect, which is also part of the assessment that is key for neurological patients, especially stroke and others. Yes. Another key item is the diaphragm also, which is also important in the okay, thank you. So so this is also important. So it's not just the muscles that we just talk about in the back and the abdomen. So there are also other muscles, including the upper limb muscle, the muscles acting on the scapula, the muscles acting on the lower limb too. So yes, what are the functions of these muscles? They have motor functions, which that's what we are talking about. We'll talk about muscle strength, we'll talk about coordination, we'll talk about endurance and other things. They also have sensory functions. And one of the important sensory function is the proprioceptive function. Yes, especially the rotators and other muscles in the spine, they are key in detecting the position of the trunk, and also in ensuring stability, balance control, and many other aspects related to this. Yes. So that's why anticipatory postural adjustment, yeah, they're involved in the anticipatory postural adjustment of the trunk muscles. So they play a major role in maintaining anti-gravity postures like sitting and standing when reaching out a task. So that is why these muscles are very, very important and are very key. I've just mentioned some of the motor function, which is the coordination, which is the strength, and which is the endurance. So we'll be looking at the function of the muscles through the trunk assessment test that in a bit when we come to this test. Yes. So these trunk muscles as the way of function and maintaining posture, maintaining mobility, they vary a lot with the extremity muscles. In which, for example, the abdominal muscles need a stable origin to act efficiently. When we look at, for example, I'll come to discuss the, or maybe I have to talk about it before coming down to this. These muscles, can we still see the slides, please? Just a response so that I'll continue.
Yes, sir.
Yes, sir.
Okay,
We can
thank
see
you.
it.
Yes.
Yes, sir.
I had during the presentation, yes, the first presenter is talking about the pelvic rocking and scooting. Yes, so that's why I said, okay, let me just add to the discussion about the various movements that are available in the trunk, because only when we know this trunk movement, then we'll be able to effectively assess them, and we know that there's a problem somewhere, and we can effectively come to manage this problem. When we look at the tests, especially the trunk impairment scale that we'll be looking at, it's around all these trunk movements here that I'm mentioning. So we have not all of them, at least a few of them that are most difficult. So yes, we have flexion extension, which we all know. We have the anterior flexion, that is then the extension that's to take the spine backwards. Then we have the lateral flexion to the right. We have lateral flexion to the left, and we have all the muscles that act on this. We have axial rotation to the right, and we have axial rotation to the left. I added another axial rotation because that is the point I wanted to discuss about the muscles before I thought I should explain the movement before going back to discuss it, which may be a bit complicated. So it will be easier to understand if I talk about this. When we have the axial rotation, we have the upper trunk. For example, when the interest is to rotate the upper trunk, we have the upper trunk rotating with a fixed lower trunk to give it that support. Because without that support, that upper trunk cannot effectively rotate. Then it can rotate to the right, it can rotate to the left. Then the lower trunk also can rotate with the fixation of upper trunk. That's when you can rotate the lower trunk to the right or lower trunk to the right, to the left, sorry, right or left. So that's why I mentioned axial rotation to the right, axial rotation to the left. For example, the upper trunk, you can rotate it to the right and to the left while the lower trunk is fixed. Then you can rotate the lower trunk to the right and to the left while the upper trunk is fixed. Very good example is when you are sitting down, just rotating your scapula or shoulders to the right and to the left. That is upper trunk rotation. Or you can do that in line, or the typical exercise we give to patients. We ask them to place their fingers in between each other. That's the upper limb. I mean, you ask the patient to place the fingers in between each other. I will ask the patient to stretch the upper limb, to straighten the elbow. Then we ask them to rotate from side to side. This is upper trunk rotation. Or we do that usually in lying position. We ask them to rotate it from side to side. Or we lie down, for example, in a supine lying position. by, for example, asking the patient's knee to be flexed, almost the heel of the feet touching the buttocks. Yes, the hip, which is also, there is a bit of flexion too, almost to around 45 degrees from extension. Then you ask the patient to roll the knee down from left to side. That is lower trunk rotation. So that is possible when there is fixed upper trunk, then you have lower trunk rotation from right to left. The same thing with the upper trunk. You can have the rotation when you have fixed lower trunk. So this is about the axial rotation. Then we have the pelvic tilt, the pelvic rocking or the pelvic scooting. And that's what Dr. Jibrin Samani was explaining during one of the tests that he was talking about. It's just like you ask patient to, it's a developmental movement, usually obviously seen in children, which we don't usually engage in much, but absence of that movement is a problem in especially in neurological condition and stroke patients, which is also one of the ways we can use in the assessment to know there's a problem, and also have been used in the treatment. So apart from this, we'll come back to the lateral flexion. You can flex laterally with the upper trunk lateral flexion to the right. When you laterally flex, you laterally flex to the right or to the left, but that is the upper trunk. You also need to flex laterally the lower trunk to the yes, on the right side or on the left side. You are not moving to the right or to the left, sorry. You are laterally flexing the right side or laterally flexing the left side. That is for upper trunk. For lower trunk, just typical example is asking patient to lift his buttocks. Just asking the patient to place his hand under the buttocks, to lift the buttocks and place his hand, or you place your hand under the buttocks of the patient. He has to lift the thigh. He has to lift the pelvis. By way of that, he's flexing laterally, but the lower trunk. Then to the left also, the same thing. You can ask the patient to lift the buttocks. If he cannot do, if he cannot do, by way of explanation is, you ask him to place his hand or place something under the buttocks, that he has to lift it. He has to lift side. I mean side, not the whole buttocks, side. Ask him to lift one side, right side, for example. Ask him to lift left side. That's also lateral flexion, but to the lower trunk. Yes. So looking at this movement, which I believe if we go into the assessment may not be too much confusing. Yes, this is the example. This is the English I was trying to talk about. Yes, that you need this stability for a certain part for you to be able to move a certain part. If that is missing, then that's when the patient have to bring in compensation. That's when you see exaggerated spasticity and many other things coming up. And that's why you see in some of the tests, they will say if the patient compensates by making A, B, C, D, then he scored 0 or you score him low, because that particular muscles that are supposed to act and effectively execute that task are lacking in two of their functions. So this is just an additional example. I mean, additional explanation. So the trunk rotation of the trunk, different. Like I said, it's different from the mechanism is different from the upper limb, lower limb. Yes. So there is a proximal stability to distal stability. Yes. The proximal, whichever way the movement you are looking at, either the proximal, that is the primary movement, then the distal is the stability that will allow for the proximal, or the other way around, whichever one, whether you are moving upper trunk, for example, or you are moving lower trunk, or you are whichever movement you are making. So counter rotation between upper and lower trunk is the example of mobility over stability. Yes, and we have stability over stability also to be fixed and be able to maintain in that posture without movement of both parts or both segments. I've already summarized or talked about this is a very extensive topic, but at least maybe by my summary, maybe we're able to grab some things here. So what are the impairments that we usually have on stroke patients in the trunk that we need to assess? We have this belief that, yes, it's true, hemiplegia affects unilateral limb activity. That is, it affects one side. It could be two sides, for example, when there is a bilateral hemispheric affectation. But usually, for a case of hemi, for example, we know that there is unilateral limb activity. Yes. So, but when it begins to deteriorate, it's not just only one side activity. That is one of the things that we always focus. Although I'm not going into trunk management or of stroke patients or anything to do with that. But I think assessment, rehabilitation, assessment, and management, they usually come hand in hand. So maybe I'll be talking about some things about management. So please bear with me. So because when there is affectation of, let's say, right side, there's going to be shortening of that side. Over the period, there's going to be adaptive lengthening of the other side. So the effect is not just on the side that is weak, that is shortened. There will also be a problem on the other side, which will lengthen and will not be able to shorten as functionally until with treatment. So the trunk should be treated holistically, not just one side or one aspect of it. So there's weakness just anterior, posterior, with flexion, with extension, with lateral flexion. All the flexions I've mentioned, with rotation, all the rotations I've mentioned. There's a problem with the pelvic movements, because all these things are important. When we look at our normal gait pattern, that's when we will appreciate most of this movement. And that's why when one stroke occurs and they are ambulant and we'll see their movement is deficient. And one of the things is also is because of the trunk. It's not just because the lower limb or the upper limb there. One of the things is because of the trunk. You see the trunk rotation missing. You see the pelvic movement and many other things missing. But most of the time, our so still on the trunk muscle impairment, the trunk muscle strength is the trunk muscle strength is impaired multidirectionally. I've just mentioned it, anterior flexion, extension at all directions. And the sensorimotor impairment also there is also sensorimotor impairment, not just the motor as we are talking about. We say there are also some sensory roles or functions. So this together will now impact on the overall function of the stroke patients. So what are the consequences of this impairment? One, when there is poor trunk control at admission, there is associated longer length of hospital stay in rehabilitation? Somebody just raised their hand.
Yes, sir.
I don't know if
Yes,
it's
sir.
a
It's me.
question.
Yes, it's me, sir. Hello, sir. I have a question,
Yes,
sir.
yes, ma'am. I'm
I'm so
listening.
sorry. I don't want to forget. That's why I just want to quickly ask the question.
Okay, ma'am.
Yeah, thank you for the wonderful presentation so far, sir. So my question is from, I don't know, I may be wrong, I don't know. So from my past experience, I always have it in mind that in a stroke survivors, one like hemiplegia, as you have said earlier, that one side may be affected depending on the side of the brain that is being affected. So
Yes.
now from this recent slide, you said irrespective of which that the trunks are are affected on both sides. So I'm not really clear, but I don't know whether you
Okay.
can help to
Okay.
shed more
Okay. I'll
light.
okay.
Yeah.
Okay. I'll explain further what I mean. Okay. Typical example is if we look at the movement in our upper limb, let's say the brachial aspect, let's say the arm, let's say we have majorly the biceps and the triceps that are involved in flexion and extension. When the biceps is contracting concentrically, that's into flexion, it's contracting concentrically. The triceps is contracting eccentrically to allow for a graded movement. If there's a problem or there's a weakness to the triceps, that biceps cannot function effectively. So when the bicep, for example, become shortened or become spastic or becomes when there is a over a period of time, it become that it develop contracture, for example, that will also affect the function of the triceps because they work together. So that's what I mean by if right side is affected, for example, and it's shortened, that other side will be forced to lengthen and it will remain in that position. It could develop all other impairment as a result of the lack of movement, as a result of the adaptive lengthening and the many other things could occur, not primarily because of the stroke. Maybe let me mention this, not primarily because of the stroke, but it's an impairment that occurs secondary to the impairment on the affected side that is coming later because they work hand in hand. This is a statement I've just mentioned here, that both sides are needed, just like the biceps and the triceps, that they work together. We have the agonist, we have the antagonist. One is contracting eccentrically, one is contracting concentrically. If one cannot do the normal function, then the other one will not be able to do its own. And it will be over the period of time, it will be doing that wrong, impaired, or a poor or a deficient activity or function. And over the period of time, then you end up with two sides that have problem. I don't know if this have answered
Yes,
have
yes, it's
attempted
answered.
the
Yes,
question.
thank you, sir.
It's not
Yeah,
primarily because of the impairments in the brain and
yeah.
the other side is affected. Maybe this has cleared the air.
Yes, sir.
So
Thank you, sir.
yes. So when you have a patient, I've also had this from the first presenter. He has made a lot of points in trying to explain this. Yes, that poor trunk function at admission for stroke patients is associated with longer length of stay in the hospital or in the rehabilitation ward. So at the beginning, patient has poor trunk function activity or control, then is most likely to do not to do better than a patient with a better trunk control. So it also another study. These are studies. Sorry, I didn't cite them because of time factor. I just want to bring the information. There are a lot of citations which I have not placed. These are not my statement, of course. Yeah, better in initial trunk function is associated with longer distances with speed at discharge. The same thing. I think they are just similar statements, but they are from different studies. This also additional study that supported the same statement. Early unsupported sitting balance is associated with the ability to ambulate independently at discharge. They are all saying similar thing, but in a different way, because there are different studies, there are different category of activities, but they have similar conclusion. So this is to say that when there is affectation of the trunk, it means it's an indicator, or is yes, it's an indicator of prognosis. Yes, and this also will tell us where we should lay much emphasis. Apart from, we do other exercises for the limbs, for the upper limb, for the lower limbs. Yes, we try to prevent, we try to improve on many things, but trunk is never a thing to ignore. So I've stated this earlier in the presentation that when these functions are lost and the muscles cannot be able to effectively execute these tasks, then that's when you will see spastic patterns, synergistic patterns. You see upper lower limbs compensations and a lot of things. So when you see compensations, you know that the trunk is deficient, and you need to know where that deficiency is. So trunk assessment. Rehabilitation after stroke focuses on hemiplegic upper limb and lower limb. This is the statement I just finished saying, or I just concluded on just saying now. Yes, that all our focus most of the time is we look at upper limb, lower limb. We want to see the patient is upright. We want to see the patient begin to ambulate, take him to parallel, take him to tilt bed or tilt table, or all activities that we do surrounding upper limb and lower limb improvement. Yes, but little attention is paid to trunk. We always try to ignore it, not really deliberately, but it's because we always look at the limbs as those things are most important for ambulation or for upright position. But the trunk is that which give the stability for the limbs to function. The upper limb needs the trunk, needs a very functional trunk to be able to carry out ADLs with the upper limb. We need a functional trunk to be able to carry out ADL with the lower limb, including ambulation, including right from sitting, standing, and other mobility or movement or ambulation. So, and that is why you see focus of many treatment approaches. For example, what the ones I'm most familiar with, you talk about the PNF, there is specific patterns that are deployed for trunk. The pelvic patterns plus the scapular patterns plus several combination of such. We do it in sitting, I mean, in lying, in sitting, in standing, and many other ones. Also look at Bobart's, adult Bobart's concept. They also have similar, not similar, but also they have a lot of focus on the trunk activities. And that's why they have the key point of control in which the trunk is a very significant part of that aspect. So that aside, we want to look at, want to start looking at some of the tests. I've mentioned 2 tests, which we'll be looking at by God's grace. I wouldn't want to take much time, but at least I've already taken some time giving a background of especially the movement and what is expected. Yes. So functional reach test. This is a test that is used to assess, that was developed by Dunker, yes, and in the 90s, it is used to assess how one can, or let me say limit of stability, yes. And it assesses the maximal distance a patient or an individual can reach beyond the length of their arm while still maintaining their base of support, which is a fixed base of support. So there are different sections of the functional reach test, but before that, we look at the psychometric properties and some of its features. And we have functional reach test as which has a very good inter-rater reliability. That means assessment between two practitioners or two professionals or two clinicians will not be too different, if I can say that. You see ICC, interclass correlation of 0.98, which is very high. And it's very simple to perform. It takes about just a minute to complete and score. Could take more than that. It depends on the expertise and how you've been doing it frequently and able to do it faster, more efficient. Yes, it's a valid tool and predicts risks of fall in the stroke and the elderly. Yes, and it represents how far subject can move their center of mass over their base of support. Even though this statement is questionable because with some newer tests which are objective in the movement laboratory, this has been tested and found to be not very true. Yes, but despite this, it's still a very good test to predict risk of fall, and some modifications were made on the test, just like what last week we have mentioned on type up and go. We've seen some modification which some tasks were added to take care of some of its limitation. Yes. So this test measures distance a person can reach beyond the length of their arm. So the subject are asked, or the patient or the individual are asked to reach as far forward as they can while standing independently. They are not holding anything. Nobody's holding them. They are just standing, and ask them to reach out as far as they can, to reach forward as far as they can while maintaining a fixed base of support. This is just a picture trying to show an example. This is a forward reach test. Yes, ask the patient to reach the arm forward as far as the patient can. So the arms should be maintained at 90 degrees. The patient is, or the individual is standing erect, and the patient or individual should not step out, because when the patient step out, it means he has gone out of the limit, out of his or her limit of stability. And we have learned from the previous class, from the previous presentation, sorry, that that's one of the strategy. Balance strategy is also stepping out to avoid falling down. And that's last aspect of it, because if somebody step out, then you know that it's almost falling down. So there will be a mark if the patient or individual is asked to stretch out the hand forward, probably standing close to a wall. The patient will stand at first at this particular position, and the patient will reach out the arm at 90 degrees, the elbow straighten, and a mark will be taken at the starting position, at the neutral position, where the patient is just standing without performing any task. Just the arms at 90 degrees, like we can see in the picture, standing erect, elbow straighten, then mark is taken. Then the patient is asked to reach out as far as he or she can. Then a mark will be taken again, and the distance will be taken between the first mark and the distance the patient is able to reach. A distance of less than or equal to 15 centimeters or 6 inches predicts risk of fall. Or the patient's step out, it means he has also failed the test because is at risk of fall also. So it depends. There are some modifications too that were added to this test. And one of the modification is, or the two modification is, one is lateral reach test. What we have, what I just demonstrated now is a forward reach test. Then what is added is to reach out laterally, to flex laterally to right side or to flex laterally to the left side. Then to also reach out backwards. So these are just some modifications. These are newer things, and they're still in development of these figures and other things. Yes. Then the last instrument we'll be looking at is the trunk impairment scale, TIS, which is a very common test or scale, a popular test, which we are all familiar with. It measures motor impairment of the trunk, which is abbreviated as TIS. It measures also coordination. I've mentioned about the function of the muscles at the beginning. We have the motor, we have the sensory aspect, we have the coordination, we have the static and dynamic balance of the trunk. Yes. So these tests assess static, assess dynamic, sitting, but it's in sitting. And unlike the functional reach test, which is in a standing position, then, but of course, it's assessing trunk also, but in standing position. But this time around is in sitting position. I learned also in the morning, the tests we have seen, I think almost all of them in sitting position. So it assesses both static and dynamic. Then it assesses coordination also. It has a section for coordination. So it has static section, dynamic section, and coordination section. Then this was developed around, yes, before 2004, because the publication, this is where I got the information. It's a paper published by Verheiden in 2004. I think it was a professor in KUL, yes, if I can remember. And it's also supervisor to the current registrar of MRCB. So he's a very known person in stroke rehabilitation. Yes. This trunk impairment scale has a very excellent psychometric properties, which is used in the clinical practice. I mean, psychometric properties for use in clinical practice and stroke research. So it's an excellent tool for research because of its psychometric properties. It has an excellent reliability. It has an excellent internal consistency. It has an excellent validity. Another participant is raising a hand. Yes, sir. Hello, sir.
Good afternoon, sir. Thank you so much for your presentations. Yeah. Please, I have a question so that for me to have more clarification. As I know this presentation is more of a balance assessment specific to the lower extremity in a patient with stroke and Parkinson disease. So my question is, how does the trunk impairment of stroke differ from that of Parkinson disease? Thank you so much.
Okay. This particular instrument we're talking about is, it affects the, okay, let me take this off. Was developed specifically for stroke, so specifically for stroke patients. That's those are the participants that it was developed for, and those are the participants it was also validated for and also being used. I don't know whether it has other validities for whether it's valid for. I'm not aware of that. Whether it's valid for Parkinson's disease, but this could be checked also. The trunk impairment for the Parkinson's disease and for stroke varies, of course, because in a stroke patient we have HEMI, that is where we have the impairment, which is not the case for Parkinson's disease. One thing I forgot to mention at the beginning of assessment of for the assessment of trunk, I've always tried to mention this, that in general neurological conditions, assessment, physical tests, for you to be able to reach diagnosis, whether you're making for diagnostic purpose or prognosis or as a baseline for your assessment or for research, most of these tests, there are screening and there are also tests that you can conduct to know the level of the impairment, how much of this impairment is there. I gave example last week while I was making the presentation that when, for example, you want to screen for cognitive impairment, you ask for some of the domains in the cognition. For example, for memory, you ask the patient, what have you taken yesterday? What have you taken for lunch yesterday? What have you taken for dinner yesterday? The patient is not able to recall. Or what have you taken for your breakfast today? You're asking for memory recall. You ask the patient, where are you now? What is today's day? What is today's date? Is it night or afternoon? That's orientation. From there, you're able to know that, yes, there are some things missing about the cognition. Then for trunk, for example, right from the position of patient in lying and in sitting or in standing, you can observe impairment, symmetry, asymmetry, compensation. Like I've just mentioned, compensation you see in or involving the upper or lower limbs in the patient, the stroke patient, and so on. You could know that, yes, that is an impairment. Then, okay, you now go straight and pick the appropriate instrument you want to use to assess the impairment, especially, for example, like we are discussing about trunk. But yes, for coordination also, you can also ask patient to sit from lying, and you see in coordination of how the patient is sitting up from lying position, you know that, okay, there's a coordination problem and you need to assess coordination in trunk. So, like I said, there are screening tools or ways of screening. Then that's where you go after screening into your proper assessment, because these are some of the things that are usually done, whether to know something is there or not. Sometimes you may not be able to see it, obviously, with the screening, but it may tell you a bit, instead of just carrying a whole instrument, a whole lot of papers to start straight assessment, and at the end you'll not be able to see any impairment. But there are just some screening question or screening ways that can be done. Like I said, in most of the neurological assessments for sensory, for motor, and many other things, that are this kind of screening you do for cognition, and many, not just cognition, for psychological tests. There are a lot of screening you do. Then you go straight to the assessment, or any tool that you can grab, which is appropriate for that condition. Then you use to assess, then to know how much of this problem is for your own use to know whether your patient will be improving or not, or your patient has improved or not after your treatment. So the overall possible score is 23, and the least score for and the least possible score is 0. Yes, this is just a summary about the overall test before conducting the test. The starting position for each item is the same from beginning to the end. The starting position is sitting. So the patient has to sit, yes, a sitting position on the edge of the bed or treatment table without back or arm support. So just like the normal couch we have in the clinic, we can just ask patient to sit without any, just like the normal tilt or normal couch or table that we use for treatment. The thighs make full contact with the bed or the table, so it's fully seated. The feet are apart from each other. Then the feet are flat on the floor. Then the knee is at 90 degrees. The arms rest on the legs. Just the normal sitting position. So if there is hypertonia, which I've mentioned in my introduction, we assume that is the best position that the patient can hold or can be. Then we assume that is the starting position. The head and the trunk are in a midline, so that the head will not be on the other side, except, yes, there is a so unless there is that is the impairment, which is the head cannot be in that position. So if the patient scores 0 on the first item, that is the easiest task that the patient can do, the item 1 of static sitting assessment. If the patient cannot do that first item, then don't even bother going to any other item. So each item can be performed 3 times, and you take the best of the score. So you take the best of the score. You can do it once, twice, thrice, then you take the best of the score. The patient can be instructed verbally on how to do it. There is no correct, you don't correct them. You can ask them on, but no demonstration. Sorry, you don't demonstrate, but you can verbally give them the instruction on how they can do it, on how they can best do it, but you don't demonstrate to them. Yes, and there's no, you don't allow them to practice before they do it. You instruct them, they do it. They do it 3 times, you can take the best score out of it. So the score is usually 0, 1, 2, cannot perform partially and fully. So it depends on which of the tests that one is performing. Yes. This is what I just mentioned. The practice, there is no practice session. The patient can be corrected between attempts. Yes, you can verbally explain it, but yeah, you don't have to demonstrate it. It's just verbal instruction you can explain to them. Yes, you can demonstrate, but you don't allow them to practice. That is one of the things that is most emphasized, not to allow the patient to do. Don't allow them to practice it. So we start from like I said, there are 3 components. Okay, I didn't mention there are three components. We have the static sitting balance component. We have the dynamic sitting balance component. We also have the coordination component. So starting from the static sitting balance, is just to ask patient to sit, just the normal sitting position we have explained earlier, just to sit without just to sit without support, with the hands on the thigh, with all those explanations. If the patient falls or cannot maintain starting position for 10 seconds without arm support, you score the patient 0 on this item. The patient is scored 1 if he can maintain starting position for 10 seconds with eyes closed. The patient can maintain for 10 seconds at the beginning, then ask him to close the eyes. If he can do that for up to 10 seconds, then you score him 1. If the patient scored 0, this eyes closed, sometimes that's why I have it in bracket. You see in some texts with eyes closed, some without eyes closed. In the main publication, which I extracted this explanation, which was published in 2004 by Verheiden, they didn't mention with eyes closed. But I've mentioned that some tests, some assessment tools, some screening tools, or some skills undergo a lot of changes with modification over the years. There are some short form of this test I've seen, but I don't know the validity, the psychometric properties of those the short form. That is why I didn't bring it here, and that's why I also saw this with eyes closed. Yes. So I've mentioned at the beginning that if this individual is called 0, the patient cannot sit down unsupported for at least 10 seconds, then you don't need to further take any test further. The patient scored 0 overall, and that's all. So go to item 2. In item 2, the patient is still maintaining that particular position, but there's going to be a change or modification in which the therapist will cross the unaffected leg of the patient over the hemiplegic lower limb. So patient falls or cannot maintain sitting position for 10 seconds without arm support is called 0. Patient is called 2 when patient can maintain sitting position for 10 seconds. He can do that, he's cleared for stage 3. So for stage 3, what you do is to cross the unaffected over the affected. What we have here is the therapist crossing unaffected over the hemiplegic or the affected. This time around, the patient will do it actively, will cross unaffected leg over the hemiplegic. If patient falls on the bed or on the tables, it scores 0. If the patient cannot cross the legs without arm support, it means he has to place the hand on the bed, on the table, to support himself and cross the leg. Then it means he scored 1. If the patient crosses the legs but displaces the trunk more than 10 centimeters backward or assists crossing with the hand, he uses his hand. We usually see this at the clinic. You ask patient to do this. You see them taking the unaffected, taking the hand to cross the affected unaffected over the affected or affected over the unaffected. But you see them using their hands to do that instead of actively doing it. So it's called 2. Patient crosses the legs without displacement or assistance. He does it by himself without showing any sign of weakness of the trunk or impairment. Then scores 3. So that's for the dynamic sitting balance assessment. Then, for the static sitting balance that we assess for the trunk impairment scale. Then for the dynamic sitting balance, we have item 1. In the first item, patient is instructed to touch the bed or table with hemiplegic elbow. This is now lateral flexion. So you ask the patient you can ask him to cross the fingers into each other. You ask him to place the elbow. That means he's laterally flexing towards the hemiplegic side for the elbow to touch. So if he is able to touch it, if he's able to go into the side flexion to the unaffected side to touch it, that means this affected side will be shortened and the unaffected side is going to be lengthened. And that's what the explanation I was trying to give at earlier introduction. The affected side is shortened, the unaffected side is lengthened. And then you ask him to return back to the starting position, to go back, touch the elbow and come back. But you observe whether he's able to go and reach the table or the couch with the elbow, and there is also shortening of the affected side, and there is also lengthening of the affected side, and it's able to return. If it's able to do that, you score 0 if patient falls, needs support from an upper extremity, that he needs to do some compensation with the upper limb for him to be able to do that. Then if patient moves actively without help, elbow touches the table, then is 1. He's unable to do it, 0. He's able to do it all with some support and some compensatory mechanism you see, then is 0. He's able to do it, is 1. If patient scores 0, then there's no need for you to go through item 2 and item 3 for this dynamic sitting balance. So what are these item 2 and 3? They are barely repetition of this. So that's why they say if he's able to do it, you just go to the next one. So you repeat item 1 that we have just passed, which is asking the patient to touch the side using the going through the affected side, touching the elbow, touching the couch or a table with the affected through the affected side with the affected elbow. Yes. Patient demonstrates no shortening of the side or no lengthening of the unaffected side, is 0. Patient demonstrate appropriate shortening and lengthening, because it's supposed to shorten and lengthen all the way. These are also some ways of treating. I said I'll be talking about this hand in hand. These are also some ways of treating patients' trunk impairment. You have stroke patients with this limitation, then you focus on treating this particular aspect, this particular lateral flexion to the right or to the left, ensuring lengthening and ensuring shortening of this. There are a lot of various exercises that are being conducted based on various approaches. If score 0, then item 3 is 0. If you cannot do this, then you cannot do item 3 also. Item 3 is repeat item 1. When patients compensates, what are these compensation that we have mentioned? Use of upper extremity. He used the he is making movement, taking the elbow closer, doing all manipulation to ensure that he's touching the table, not appropriately shortening the side. He's just pushing the hand, not just shortening the lateral aspect of the trunk. Or there is contralateral hip abduction. If we remember at the beginning of the presentation, I've talked about these compensations that usually comes when there is weakness or when there is impairment in the trunk. So this is an example. So then another way of compensation is hip flexion. So use of upper extremity, yes. Contralateral hip abduction. You see patient, you ask them to go towards a certain side, and you see they will be abducting, taking the hip outside. They'll be abducting it. Or they will be there will be hip flexion. They will be flexing the hip and abducting the hip. Sometimes you could see knee flexion and you could see sliding of the feet. You ask the patient to move towards the other side. Instead of just flexing, he's pushing the lower limbs to make sure that he has tilted towards the side that is supposed to touch with the elbow. Patient moves without compensation is called 1. Then item 4, patient is instructed to touch the bed or table with unaffected elbow. The first one we had was using the affected elbow towards the affected side. Now is towards the unaffected side. So if there, you check, there is supposed to be shortening of the unaffected side this time around. There's supposed to be lengthening of the affected side. And there is a return of the patient back to the starting position. So is he able to do it or not? Then you score the patient. Patient falls, needs support from upper extremity, or the elbow does not touch the bed or table, is called 0. Patient moves actively without help, elbow touches bed or table, then patient scored 0. Then you don't need to proceed to 5 and 6 because they are a repetition of this. Item number 5. Repeat item number 4. Patient scored 0 if patient demonstrates no or opposite. When there is no shortening of the side the patient is going towards, or when there is no lengthening of the affected side this time around, right? Because it's going towards the unaffected side, it means we are going to have lengthening of the affected side. We are going to have shortening of the unaffected side. So patient demonstrate appropriate shortening and lengthening, then patient is okay, scored 1. If scored 0, then no need to proceed to 6 because it's also a repetition. Patient scored 0 when there's compensation that we have just mentioned, using the feet, using the upper limb, using hip, using the knee, and many other ways of compensation. Patient did not compensate, then it's scored 1. Then item 7. Patient is instructed to lift pelvis from bed or table at the hemiplegic side by shortening the hemiplegic side and lengthening the unaffected side and return to the position. I think I've just described this during the explanation of the trunk movement. Yes, the lengthening and shortening of, or the lateral flexion that we have just demonstrated to the right, to the affected and to the unaffected side we just demonstrated are the for the upper trunk. And we now talking about the pelvis. Just ask him to lift the pelvis, like what I just explained. Ask him to place something below the thigh or the buttocks, sorry. Then you're going to have shortening of the side is lifting, and it's going to have lengthening of the opposing side. So this is just the explanation. That's why I took time to bring all those explanations so that this would be smooth. So you observe the shortening, the lengthening of the other side, and is able to return. If patient demonstrates no shortening of the side is lifting the pelvis, patient demonstrates no lengthening of the unaffected side, then the patient is scored 0. Patient is scored 1 if is able to demonstrate appropriate shortening of the side, the lifting the pelvis, and lengthening of the opposite side. If patient scores 0, then item 8 is 0. There is no need to go to 0, and the other items under dynamic sitting. One can go straight to the coordination. So item number 8. It's a repetition of 7. If patients compensate, use of upper extremity, pushing off with ipsilateral foot, that's the heel loses contact with the floor. We have mentioned that there's supposed to be contact with foot with the floor at all times. So the patient scores 0. If patient moves without compensation, is able to shorten and lengthen the sides, then he scores 1. Item number 9. Patient is instructed to lift pelvis from bed or table at the unaffected side. The same thing, but this one is unaffected side. So there's supposed to be shortening of the unaffected side, and there's going to be lengthening of the hemiplegic side. And the patient will now return back to the starting position. If able to do this without the appropriate shortening and the lengthening, then this individual scored 1. If unable to do it, then it's scored 0. If it's scored 0, then item 10 and the rest are 0. So what is item 10? It's repetition of 9. You ask the patient to lift what we said is going to lift the unaffected side. Yes. So it's able to lift the unaffected side without any compensation. It scores 1. If it's compensating by lifting the foot or by using upper extremities to make sure that he has lifted the pelvis, then the individual scored 0. Then we have the coordination aspect. Like I said, it has 3 components. It assesses static sitting balance, it assesses dynamic sitting balance, it assesses coordination also. So the first item under coordination is hello? Hello?
Yes, sir. We are with you, sir.
We are with you, sir.
I
Yes,
thought
sir.
I'm just talking to myself. I begin to check if
No.
the network. I'm surprised that something did not stop or just like last week. So I just paused and thought that maybe I'm just speaking to myself and nobody notified me. So I didn't receive
No,
any.
sir.
Okay.
Yes,
Okay,
sir.
so when things are going the way it's supposed to be, you start questioning whether something goes wrong. Because I remember last week I was moving around looking for network and so on, and today it was seamless. So we thank God for that. So the patient is instructed to rotate upper trunk 6 times, but it's supposed to rotate right side and left side three times right side, 3 times left side. How is he going to do it? He's going to rotate, that's the upper trunk, rotate the shoulder or scapula going forward. Then, for example, going the right side 3 times, also going the left side 3 times. That making total of 6 rotations. So that's what they mean. Every shoulder should be moved forward 3 times. So first side that moves must be hemiplegic side. You start movement with the hemi side, then you go with the unaffected side. But the head should be fixated in the starting, shouldn't be moving with the rotation, shouldn't be compensating. Yes. So patient scored 0 if the shoulder is not able to reach 3 times movement. Is asymmetry. It's called 2 when the rotation is symmetrical. Item 2. Repeat item 1 within 6 seconds. Rotation is asymmetrical, 0. Rotation is symmetrical, then you score the individual 1. Then item 3. Patient is instructed to rotate lower trunk. We have talked about upper trunk rotation, and that's why I decided to give some background at the beginning about upper trunk, lower trunk rotation, the pelvis lifting, the side flexion, and so on. So patient is instructed to rotate lower trunk 6 times. And I give example as somebody is lying down and moving the knee joints side to side. So this is an example, but it's going to be done in sitting position. Every knee should be moved 3 times, just like that of the scapula. The first side must be hemiplegic also. Upper trunk should be fixated, shouldn't move. So the individual scored 0 if there is if it's not able to move up to 3 times, and is able to move with symmetry is 2, with asymmetry is 1. Then patient is called 0. If the patient scores 0, sorry, then item shouldn't go to item 4. That means it's able to get item 4. If that's here is item 4 now. You repeat the movement 6 times. Sorry, you repeat item 3 within 6 seconds. Then if it's able to do it asymmetrical is 0. Is able to do it symmetrical is 1. So this is overall the instruction for the assessment of trunk impairment scale. And as I mentioned, it has overall score of 23 and a minimum score of 0. Yes. Thank you very much. This is in a summary, the 2 items. Like I said, we are taking two items. Yes. There are other tests which can combine this plus other tests for trunk and for other activities, mobility, and so on. For example, back balance scale, which is a popular one that we know, which can also be used. So at this juncture, maybe we can take a discussion, not necessarily question, because if a question is asked and somebody from the audience can respond, we'll also learn. We're in a learning ground. Yes, thank you very much for your audience, and I hope we have gained 1 or 2 things from the presentation, and thank you for your patience.
Okay, thank you, sir.
Yes, I think somebody's raising a hand.
Yes, sir. It's me, Satmishe. Thank you very much for the presentation so far. It's actually a wonderful one. I
Thank
just
you very
have
much.
a little question anyway. So in regards to the functional risk test, is a popular test. I like the test very well. But you made
Yes.
mention of some modifications in terms
Yes.
of a lateral reach and backward reach. So my
Yes.
question now is, in a situation whereby my patient passed the functional risk test, then I was trying to do the modifications. So my patient is unable to do this lateral and backward reaching. So what's not the indications or the implications of not be able to do lateral and backward reaching? Does that guide in my intervention, or I don't know, like what do you think about this, sir?
Yes.
You get my question, sir?
Okay, let me say I understand it. If I attempt it, then you can respond if I have done justice to it.
Okay, sir.
When assessing balance and gait also comes into, and like what Dr. Jibril Samani talked about, reactive balance, balance adjustment control, and all those stuff, they have a limitation that they're only looking at when things comes at the in front of you. And what happens if things come when you look at the balance strategy? Some of the common ones are, yes, we have the ankle strategy. That is what is being used. We have the hip strategy. That is, it depends on the strength and the balance control of the individual. So some will step out, some will use the anterior, some will use, sorry, the hip strategy or the ankle strategy. So it depends on where the perturbations comes. But what they are assessing only is when it comes to the anteriorly. And they now realize that, okay, we need to check the lateral sides. We need to check. When you check at the limit of stability that we had last week, it's both anterior, posterior, and laterally. And that's where I also showed a picture of, sorry, I don't know if you are with us last week. Sorry. So I showed a
Yes,
picture of,
sir. Yes, sir.
I showed a picture of Michael Jackson doing that forward, going beyond the limit forward. And we said that is not possible to do those things. So they have also thought afterwards that, okay, there are also some things that are missing that we need to look at it. Yes, it's going to affect the management, it's going to affect the, when you look at assessment of balance in mobility, or let's say gaits that we usually do, we don't just assess. I was taking this with the MSc student just some weeks back, and I was telling them that when you assess patients, for example, you don't just say, "Oh yeah, Baba, walk," and the patient just walk and come back, and you say, "Okay, the gait is good." Ask the patient to walk backward. Ask the patient to run. Ask the patient to walk fast. Give some cognitive tasks to the patient. It's adding more difficulty to the task that is doing, and that's when you see, those are probes. Those are probes, like I mentioned in the last presentation. Those are more probes that will bring more of the problem. You are just we have said some of these tests have ceiling effects. Some have but they are just not able to see some much more information. So when you do this more, you are going to see much more information on the problem that you are assessing. Thank you. Another person has raised hand. Sorry, I don't know if I have attempted the question.
Yes, sir. Thank you, sir.
Okay, thank you. Somebody has raised hand again. Or maybe he's not close by. Or maybe it's a mistake. Okay, so I think it's a mistake. The same person is writing a message. Yes. So, Dr. Jibril Samani, over to you, sir.
Okay, thank you so much for the in-depth presentation. We appreciate it. I will also thank all the participants for the attendance. Wishing you all the best and see you in the follow-up hands-on and practical workshops in future. Soon, the flyer will be out soon. Thank you so much.
Thank you, sir.
Okay,
Thank you
sir.
all. Thank you all
Thank
for
you,
the
sir.
participation and thank you for your patience. See you next time.
Thank you, sir.
Thank you.
Thank you so
Thank you
much,
very
sir.
much.
Thank you.
Thank you very much.